Okay, so next topic is hematology. In hematology, the medicines are antiplatelet drugs. So, who will tell me the names of all these medicines which are antiplatelets? So, we have a drug which is an irreversible inhibitor. There is a medicine which is an irreversible inhibitor of COX-1 enzyme. And by inhibiting this enzyme irreversibly, that is COX-1, this will reduce the synthesis of thromboxane A2. So thromboxane A2 synthesis will go down and medicine has antiplatelet property, right? So who will tell me the name of the drug? So the name of the drug is aspirin. Name of the medicine is aspirin, and this medicine is used in a dose 75 milligram to 325 milligram. So medicine is used in a dose of 75 to 325 milligram. Now we have medicines which are P2Y12 receptor inhibitor or ADP receptor inhibitors. ADP receptor inhibitor, P2Y12 inhibitors. So here we have two types of medicines. There are three medicines which are irreversible inhibitor. There are three medicines which are irreversible inhibitor of this receptor. Medicines are clopidogrel, prasugrel, and ticlopidine. Now these medicines which are irreversible inhibitor, their action lasts for 4 to 5 days. So these medicines should be stopped. These medicines should be stopped 4 to 5 days before surgery. So these medicines should be stopped 4 to 5 days before surgery. They are the irreversible inhibitor like clopidogrel, prasugrel, ticlopidine. Now clopidogrel, which is a prodrug, this is activated in human body by CYP2C19 enzyme. So this medicine is activated in human body. So clopidogrel is a prodrug. This is activated by CYP2C19 enzyme in human body. Now second type of medicine here is reversible inhibitor. We have one more medicine here which is reversible inhibitor. So we have some irreversible inhibitor. We have a drug which is reversible inhibitor. So the medicine which is reversible inhibitor, drug name is ticagrelor, and this medicine has short action. This medicine has short action in the body. So this should be stopped 1 day before surgery. So this should be stopped 1 day before surgery. So ticagrelor should be stopped 1 day before surgery, and above medicines which are irreversible inhibitors, they should be stopped 4 to 5 days before surgery. So irreversible medicines 4 to 5 days and the reversible medicine 1 day before surgery. But if you talk about aspirin, aspirin is a drug that can be stopped. That can be stopped 3 days before surgery. This can be stopped 3 days before surgery if patient is taking the medicine, if patient is taking the drug chronically. So patient is taking medicine chronically, right? So patient is taking this medicine since long time, then the medicine can be stopped 3 days before surgery, but do not stop the drug. Do not stop the medicine if it is started recently. So do not stop aspirin if started recently. So aspirin should not be stopped if started recently, but can be stopped 3 days before surgery if taking it for a long time. So this is for the aspirin and the medicines which are P2Y12 inhibitor. Now we have the drug which is PAR1 inhibitor, or we can say the medicines which are thrombin receptor inhibitor. So PAR1 inhibitor, thrombin receptor inhibitors. So this is a drug known as vorapixar. So vorapixar is the drug which belongs to this class. Now we have the medicines which are glycoprotein 2B3 inhibitor. So glycoprotein 2B3 inhibitor, drug name is epsiximab. So epsiximab is the drug which is glycoprotein 2B3A inhibitor. It's glycoprotein 2B3 inhibitor, and it is the only antiplatelet drug that is not only, it is the drug which is given only by IV route. So this is the medicine that is not given by oral route. This is the medicine that is given only by IV route. So this medicine is the one that is given only by IV route, and it's the most efficient antiplatelet drug available in the market. Most efficient antiplatelet medicine is epsiximab, given by IV route. It's a glycoprotein 2B3 inhibitor. Now we have some medicines which are phosphodiesterase enzyme inhibitor. So medicine which is phosphodiesterase enzyme inhibitor, drug name is dipyridamole. So drug name is dipyridamole, and we have one more drug, cilostazol. So cilostazol, dipyridamole, are two medicines which are phosphodiesterase enzyme inhibitor. So dipyridamole, cilostazole are phosphodiesterase enzyme inhibitor. So these are the five group of medicines which are used as antiplatelets. Now, these antiplatelet medicines are given to a patient who suffer from angina, myocardial infarction, transient ischemic attack, stroke, or gangrene. So these are the five indications where we start antiplatelet drugs. So antiplatelet drugs are given for cardiac condition like angina and MI, given for CNS condition like transient ischemic attack and stroke, and can be given for gangrene. Now, whenever we have to start antiplatelet drug, we always start two antiplatelet together. We always start two antiplatelet together. So we call it dual antiplatelet therapy. We call it dual antiplatelet therapy. And in this therapy, the most common combination is between aspirin and P2 Y12 inhibitor. So this is the most common combination that we use in clinics for the treatment of these five conditions where we give antiplatelet medicines. So basically, these are the five conditions where the arteries are obstructed. So we remember like this way, wherever the arteries are obstructed, we give antiplatelet drugs. Right? So this is all about antiplatelets. Now let's talk about anticoagulant medicines. So medicines which are anticoagulants. Now these medicines are mainly given whenever the thrombus is present in veins. So anticoagulants are given whenever the thrombus is present in veins. So for venous thrombi, we give anticoagulant medicines. So anticoagulants are given for venous thrombi. Now these anticoagulants are the one which are inhibitor of clotting factor pathway. Now how these medicines inhibit clotting factor pathway? There are mainly two groups. We have two types of medicines, directly acting and indirectly acting. So directly acting, indirectly acting are two types of medicines which are anticoagulants. Now the medicines which are directly acting, these medicines are direct inhibitor of factor 10 or factor 2. These medicines are inhibitor of factor 10 or factor 2. Now let's talk about the medicines which are factor 10A inhibitors. Now the medicines which are factor 10A inhibitors, we call them directly acting oral anticoagulants. So these medicines are anticoagulants. We call them directly acting oral anticoagulant medicines. They are given by oral route. And all these medicines end with the word XA ban. So all medicines end with the word XA ban. So XA means 10A. So these medicines can ban the factor 10A. Examples of these medicines are apixaban and rivaroxaban. So apixaban, rivaroxaban, two medicines which belong to this class. So guys, please remember apixaban, one important property is apixaban is a drug which is safe to use in patients of CKD. And regarding rivaroxaban, guys, please remember this medicine when taken after food. This medicine when taken after food, its absorption is better in the body. Right? So rivaroxaban is a drug that should always be taken after food. Rivaroxaban should always be taken after food, and apixaban is a drug which is safe to use in patients of CKD. Now we have a drug which is used as their antidote, and the name of the antidote is Andixanet alpha. So Andixanet alpha is a medicine which is used as the antidote of factor 10A inhibitor. We also call them directly acting oral anticoagulants, ends with the word XABAN. Antidote is Andixanet alpha. Now we have the medicines which are factor 2 inhibitors. Medicines which are factor 2 inhibitors. Now factor 2 is known as thrombin. The name of a factor 2 is thrombin. So we also call them direct thrombin inhibitors. So these medicines are known as direct thrombin inhibitors. In this group of medicines which are direct thrombin inhibitors, there are two medicines which are given by IV route. There are two medicines given by IV route, but there is a one drug that is given by oral route. Right? So the medicines which are given by IV route, they are given for acute emergencies. These medicines are mainly given for acute emergencies. Like these medicines have thrombolytic properties. These medicines have thrombolytic property. Now because of the thrombolytic property, these medicines are used during percutaneous angioplasty. So medicines are used during percutaneous angioplasty to dissolve the clot. Right? So medicines are used during percutaneous angioplasty to dissolve the clot. So medicines are ergotroben, bivalirudin. So bivalirudin, ergotroben are two medicines which are the short-acting medicines. So they have the short action in the body, and because of the short action, we can use these during the procedure. We call it percutaneous angioplasty. But if we talk about the other drug, that is dabigatran. Now, dabigatran is a long-acting medicine belong to this class. This medicine is given in a prodrug form. It's a long-acting medicine given in a prodrug form. It is given by the oral route. And because it is given by the oral route, we call it directly acting oral anticoagulants. We also call it directly acting oral anticoagulant. The drug name is dabigatran. And this is mainly given for maintenance treatment. This is mainly given for maintenance treatment. It is not given for emergency. And this medicine has an antidote because it is given for maintenance treatment. So drugs which are given for maintenance treatment, they have the antidote. Right? So the antidote of choice for dabigatran is idarucizumab. So idarucizumab is a drug which is used as an antidote of dabigatran. So dabigatran antidote is idarucizumab. Now, after this directly acting medicines, we have some medicines which are indirectly acting. So guys, please remember, directly acting medicines are more efficient drugs. These medicines are more efficient drugs, but indirectly acting medicines are comparatively less efficient. So indirectly acting medicines, less efficient. Directly acting medicines are more efficient. Right? Why we call them more efficient? Because they can inhibit clotting factors. They can inhibit clotting factors in their liquid phase when they are flowing in the blood, as well as these medicines have property to lyse the clot. So they can inhibit the clotting factors even after taking entry in the clot. So they can inhibit the clotting factors in their liquid phase when they are flowing in the blood, as well as they can cause clot lysis. But the medicines which are indirectly acting, they cannot take entry. They cannot take entry in clot. And because they cannot take entry in clot, they cannot cause clot lysis. So they don't have the thrombolytic property which are indirectly acting. Now the medicines which are indirectly acting, they are of two types, parenteral route and the oral route. Medicines given by parenteral route, medicine name is low molecular weight heparin. Now the medicines which are low molecular weight heparin, all medicines end with the word parin. All medicines end with the word parin, and the drugs which are given by oral route, it is warfarin, and there are many drugs which have the word coumarin in their name. Right? Now if we talk about this drug, low molecular weight heparin. So low molecular weight heparin will activate one enzyme known as antithrombin 3 enzyme. This will activate antithrombin 3 enzyme, and this will inhibit factor 10 and factor 2 both. This will inhibit factor 10 and factor 2 both. But if we talk about warfarin, warfarin is inhibitor of an enzyme known as vitamin K oxidoreductase enzyme. So warfarin is inhibitor of vitamin K oxidoreductase enzyme and inhibit the clotting factors 2, 7, 9 and 10. This will inhibit the clotting factors 2, 7, 9 and 10. Now if we talk about the monitoring parameter, heparin can be monitored by APTT, but warfarin is a drug which is monitored by INR, and the second is prothrombin time. Basically INR is also a prothrombin time. So this is monitored best by INR followed by prothrombin time, and here the heparin monitoring is done by APTT. Now if we talk about the antidote, now guys, we don't have any antidote of low molecular weight heparin. For low molecular weight heparin, we don't have the antidote. So what we do, we give the clotting factor concentrate. So during the toxicity, we have to give the clotting factor concentrate. So clotting factor concentrate is given to a patient because we don't have the antidote. But warfarin antidote is there. The warfarin antidote is vitamin K. So vitamin K1 is the antidote of warfarin, but this antidote has a slow action. This antidote has a slow action. So if the patient is having the bleeding, the patient is bleeding. So patient is bleeding. So because of vitamin K has slow action, if the patient is bleeding or if the patient INR is more than 9, if the patient INR is more than 9 or if the patient is bleeding, then in that case, you have to give a clotting factor concentrate. You have to give fresh frozen plasma or clotting factor concentrate to stop the bleeding, right? So if the patient is bleeding or patient INR is more than 9, patient INR is more than 9. So in that case, you have to stop, you have to replace the clotting factors immediately. So you give clotting factor concentrate or you give fresh frozen plasma to the patient. Now if we discuss the important side effect of medicine, if we talk about their important side effect, so please remember, heparin is the drug. Heparin is a drug. This can cause hyperkalemia. This can cause osteoporosis as a side effect. So this can cause hyperkalemia and osteoporosis as a side effect. But if we talk about warfarin side effect, warfarin can cause skin necrosis. Warfarin can cause skin necrosis in first 7 days of therapy. So in first 7 days of therapy, warfarin can cause skin necrosis as a side effect. Now to prevent the side effect, to prevent the side effect of skin necrosis caused by warfarin, warfarin is always started with low molecular weight heparin, and after a few days, low molecular weight heparin will be stopped. So we start warfarin with low molecular weight heparin in first 7 days or after for 7 to 10 days. Then after that, we stop low molecular weight heparin after a few days and we continue with the warfarin. Right? Right. So this is a few important differences between heparin and the warfarin that we people have covered. Now, guys, these anticoagulant medicines are given for venous thromboembolism. They are given for venous thromboembolism. So, whenever the patient will have the thrombus present in the veins, patient can have the venous thromboembolism. The patient is in acute emergency, patient is hospitalized. So, in acute emergency or the hospitalized patient, low molecular weight heparin is the anticoagulant of choice. So, anticoagulant of choice is low molecular weight heparin during acute emergency. When your patient gets stabilized at the time of discharge, from the hospital, which anticoagulant you will give? So which anticoagulant you will give? So if the patient has undergone major surgery, risk of hypercoagulation is there. Patient is a case of DVT, deep vein thrombosis or pulmonary embolism. Patient is a case of deep vein thrombosis, pulmonary embolism, major surgery or atrial fibrillation patient. This patient should be discharged on directly acting oral anticoagulants. So directly acting oral anticoagulants, medicines are factor 10A inhibitor or medicine can be dabigatran. So you will give one of these medicines as per your tie-up with the pharmaceutical company. Now guys, please remember, whenever the valve is involved, whenever the cardiac valve is involved, like the patient who has undergone prosthetic heart valve surgery, patient who suffer from antiphospholipid syndrome, or patients who have atrial fibrillation associated with mitral stenosis. So whenever the valve is involved, then the directly acting oral anticoagulants overall efficiency is not proven to be good. So here, whenever the valve is involved, you will give warfarin. So when the valve is not involved, you will give directly acting oral anticoagulant. When the valve is involved, you will give warfarin. Right? Now, in pregnancy, we have altogether the different guidelines. So in pregnancy, whenever we have to give anticoagulants for venous thromboembolism, like all these conditions, like pregnant female has any of the condition. You want to give anticoagulants to the pregnant female. So best option is you can give low molecular weight heparin for 40 weeks. If she is comfortable, you can give low molecular weight heparin for the 40 weeks. If she is not comfortable, at least in first trimester, give low molecular weight heparin. In second and third trimester, you will again give warfarin to the pregnant female, and at 36 weeks of pregnancy, you will again shift female to low molecular weight heparin, and at 37 weeks, you will go for the delivery. Right? Because in high risk pregnancy, we don't go for 40 weeks. So we deliver the baby at 37. So 36 weeks, we will shift back to low molecular weight heparin. Now, when the patient is having CKD, or you have to give the venous thromboembolism prophylaxis. The patient is having the problem that we discussed above. You want the venous thromboembolism prophylaxis in CKD patient. So during the acute emergency, we cannot use low molecular weight heparin. Like in above cases, we have discussed that low molecular weight heparin is given. You can see here. But now we cannot give low molecular weight heparin in CKD patients. So in CKD patients, we will mark, in acute emergency, we will mark unfractionated heparin. We will give unfractionated heparin. Very good, Dr. Surbi. So unfractionated heparin is marked. Now for the maintenance treatment. In CKD patients. Now if the valve is involved, if the cardiac valve is involved, you will give apixaban. When the cardiac valve, please make a correction. When the valve is involved, you will give warfarin, because warfarin is also metabolized by liver. And if the cardiac valve is not involved, you will give apixaban. So these are the guidelines which are for CKD patients. So CKD patients who require anticoagulation, these are the guidelines that we follow for that. Right, guys? So Dr. Satish Kumar has asked a question. If indirectly acting drug has no effect on clot, then why are we giving low molecular weight heparin for acute emergencies? No, no, no. You have to understand. Uh, like uh, antiplatelets. See, if I say this is the thrombus, thrombus is formed and cause obstruction of the blood flow. Thrombus is formed that will cause obstruction of the blood flow, right? Now, the thrombus can be formed because of platelet aggregation, and thrombus can be formed because of clotting factor pathway, right? So, guys, when the thrombus is already formed and causing the obstruction to the blood flow, then we will give thrombolytics. So, thrombolytics or fibrinolytics that we are going to discuss after that. Medicines are thrombolytics and fibrinolytics. They are given to dissolve the clot. They will dissolve this clot, but they're giving only 1 or 2 doses, right? They're giving only once to dissolve the clot. Now, apart from giving this thrombolytics, we have to give antiplatelets if the problem is due to the arteries. If the arteries are obstructed, we will give antiplatelets. But if the veins problem is there, we will give anticoagulants so that the future coagulation or the future blockage will not take place. So during acute emergency, we will first of all give thrombolytics if the thrombus is already formed, if the ischemia has already started, if the gangrene has already been started. But if it is not started, if it's just a pain, if it is just to cause like in patients of angina, patient will have the chest pain. So thrombus is present. Answer is no, thrombus is not present. The obstruction is not 100%. So in that case, I will not give thrombolytics, but I will start antiplatelets. Similarly, the patient of DVT, he will come to you with pain in the legs. So pain in the legs, patient is not having the complete obstruction. So I will not give thrombolytics, but I will start anticoagulants so that the further obstruction will not happen and there is no complete blockage of the blood vessel. So this is the way we treat. The third group of medicine is thrombolytic drugs. Thrombolytics, fibrinolytics. Basically, these medicines are activator of the TPA. They will act like a TPA, tissue plasminogen activator. And when they will act like a tissue plasminogen activator, they will convert plasminogen to plasmin, and plasmin is the one that will dissolve the clot. So plasmin can dissolve the clot. There are some natural drugs. Natural drugs are streptokinase and the urokinase. And we have some synthetic medicines. And all the synthetic medicines end with our T-place. All the synthetic medicines end with our T-place. Like we have the examples, Altiplase, Retiplase. So these are the drugs, Altiplase, Retiplase, T-place. So these medicines are the synthetic medicines. All these medicines are activator of TPA. Now guys, these drugs are used only if the obstruction is complete, if the clot is already present and the obstruction is 100% complete, and that is causing the gangrene or the ischemia. So these drugs are given only for selected conditions, like they're given for ST elevated MI, they can be given for stroke, they can be given when there is a massive gangrene. So if there is a massive gangrene, then only they are used. For minor gangrene, we start only antiplatelets because the problem lies in arteries, right? In stroke, in MI patient, right, as well as in symptomatic. In patients who have symptomatic pulmonary embolism, then there is a need to give fibrinolytic drugs. Now, during their toxicity, we have to give the antidote. So, what is the antidote of choice? The antidotes are inhibitor of TPA. So, these drugs are stimulator of TPA. They will act like a TPA. And the medicines which are inhibitor of TPA, they will use as an antidote. So, the antidote of choice is IACA. So IACA is the best antidote. The second best antidote is tranexamic acid. So tranexamic acid is the second best antidote. The best antidote is IACA, epsilon amino caproic acid. So epsilon amino caproic acid is the best antidote. Now after that, guys, we have some hypolipidemic drugs. Medicines which are known as hypolipidemic drugs. So which medicines we use to reduce the level of cholesterol? So medicines which are given to reduce the level of cholesterol. So if you reduce the level of cholesterol, ultimately LDL level will also go down. So in hypolipidemic, the first group of medicines are those which are given to reduce the level of cholesterol. So ultimately LDL level is reduced. So here we have the medicines like statins. Now statins are considered as drug of choice. And these medicines are inhibitor of an enzyme that is a rate limiting enzyme. This is a rate limiting enzyme in cholesterol pathway, that is HMG CoA reductase enzyme. So these medicines are the drug of choice for hypercholesterolemia. They are the drug of choice for hypercholesterolemia. And the important side effects are these medicines can cause hepatotoxicity. These medicines can cause hepatotoxicity. These medicines can cause myopathy. These medicines can also result in hyperglycemia. Medicines can result in hepatotoxicity, myopathy, hyperglycemia, and these medicines should not be given to gravida females. So these medicines should not be given to gravida females, or we can say the pregnant females. So in pregnant females, we should not give the medicine. And we people have already covered, they are the drug of choice for hypercholesterolemia. They are the drug of choice for hypercholesterolemia, and all these medicines are preferably taken after dinner. So these medicines are preferably taken after dinner, but there are two medicines which can be taken at any time. You must be knowing the names. What are the names? The names are the medicines which are most efficient drug, like rosuvastatin, atorvastatin. So rosuvastatin, atorvastatin are the most efficient medicines belong to this class, and these medicines are the one which can be taken at any time of the day. They're not fixed to give the medicines at night time. They can be taken at any time of the day. Out of these medicines, please remember rosuvastatin is a statin which is safe to use in CKD patient, and rosuvastatin is a medicine that is safe to use in CLD patients. This is safe to use in CLD patients. So liver disease, we will use rosuvastatin. In CKD, we will use atorvastatin. Now, atorvastatin is metabolized by CYP3A4 enzyme of liver. This is metabolized by CYP3A4 enzyme of liver, but rosuvastatin is eliminated by P-glycoprotein in kidney. This is mainly eliminated by P-glycoprotein in kidney. So medicines which are inhibitor of P-glycoprotein can inhibit this rosuvastatin elimination. Right? Now we have the medicine evolocumab. Now evolocumab is the drug. Evolocumab is a drug which can inhibit. This is a second drug of choice for hypercholesterolemia. A second drug of choice for hypercholesterolemia. And this is the drug which is inhibitor of an enzyme known as PCSK9 enzyme. This is inhibitor of PCSK9 enzyme, and this is given by subcutaneous route. So drug is given by subcutaneous route. It is PCSK9 enzyme inhibitor. It's the second drug of choice. Second drug of choice for hypercholesterolemia. Now ezetimibe is a medicine. Ezetimibe is a medicine. It's a third drug of choice for hypercholesterolemia. Now this medicine can inhibit cholesterol absorption. This medicine can inhibit cholesterol absorption from small intestine. So this medicine can inhibit cholesterol absorption from small intestine. So ezetimibe is a drug which can be considered as third drug of choice. Now bempedoic acid is a medicine. Now this medicine is ATP citrate lyase inhibitor. This medicine is ATP citrate lyase enzyme inhibitor. So by inhibiting ATP citrate lyase enzyme, this medicine can inhibit the entry of carbohydrates. This medicine can inhibit the entry of glucose and the carbohydrates in liver. So this can stop the entry of glucose in the liver, and if the glucose will not take entry in liver, then it cannot be converted to cholesterol. It cannot be converted to cholesterol. So ATP citrate lyase inhibitor stop the glucose entry in the liver. Now this medicine is given to patients who cannot tolerate statins due to myopathy. So patients who cannot tolerate statins due to myopathy. So in those patients, we people have discovered a new medicine, bempedoic acid. So this is given, right? So it is given to a patient who cannot tolerate statins due to the serious side effect as myopathy. So in those patients, nowadays we are giving bempedoic acid. So this is one of the important MCQ for this year exam. Then the last group is bile acid binding resin. So any medicine that starts with the word chole is a drug that belongs to this class, bile acid binding resin. So cholestyramine, right, cholecebulum, all these medicines are bile acid binding resin. So these are the drugs that are given for the treatment of hypercholesterolemia. So after hypercholesterolemia, we have the medicine that are given for hypertriglyceridemia. So which medicine is given for hypertriglyceridemia? Drug of choice, fibrates. So medicines are fibrates. The drug name is fenofibrate. So fenofibrate is a drug. Fenofibrate is a drug. This medicine will act on PPAR alpha receptor. This medicine will act on PPAR alpha receptor, therefore activate the lipoprotein lipase enzyme. This will activate the lipoprotein lipase enzyme. This will activate the lipoprotein lipase enzyme and reduce the level of triglyceride. Reduce the level of triglyceride. So this can reduce the level of triglyceride. The drug is phenofibrate. Students, make the mnemonic like this way: FFPPLL. So phenofibrate will act on PPAR alpha receptor, activate lipoprotein lipase enzyme LL. So this is the best medicine for hypertriglyceridemia, and medicine side effects are same as statin, that is HMG. Medicine side effects are same as statin as HMG, plus this medicine can also result in formation of gallstone. So apart from HMG, hepatotoxicity, myopathy, hyperglycemia, and should not be given to gravida female, this can cause gallstones. Now some miscellaneous topic: when the patient has iron overloading, when the patient is a case of thalassemia, patient can have the iron overloading. So if the patient is symptomatic, I will give chelating agent by IV route. Medicine name is desferoxamine. So desferoxamine is a medicine. Desferoxamine, which is also known as deferoxamine. Also known as deferoxamine. So desferoxamine, also known as desferoxamine, this is given to symptomatic patient. But if the patient is asymptomatic, I have to give chelating agents by oral route. So we have the medicine like deferapon, and we have the medicine like deferasirox. So deferasirox, deferapon are two medicines that can be given by oral route. Right? So symptomatic, we will give medicine by IV route, desferoxamine, but asymptomatic, we will give medicine by oral route. Deferapon and deferasirox, these medicines can be given to a patient. So next is when the patient will have the bone marrow suppression. Now, bone marrow suppression is a side effect of anti-cancer drugs. Bone marrow suppression is a side effect of anti-cancer drugs. So all anti-cancer drugs can cause bone marrow suppression. All anti-cancer drugs can cause bone marrow suppression except vincristine and bleomycin. So vincristine and bleomycin are two anti-cancer drugs which will not cause bone marrow suppression. Most of the medicines can cause bone marrow suppression as a side effect. Now, to recover from this bone marrow suppression, we have some drugs like to increase the WBC count. We will give a medicine that is known as pegfilgrastim. So pegfilgrastim is the drug. This is given to increase WBC count. Now, to increase the platelet count, we have the medicine like oprelvicin. So oprelvicin or romiplostim. Oprelvicin and romiplostim are two medicines that we can use to increase the platelet count. Right? So filgrastim is given to increase WBC. To increase the platelet, we give oprelvicin and romiplostim. And to increase the RBC, we will give darbepoetin. So darbepoetin is a medicine which is given to increase the WBC. So increase the RBC, and this is also drug of choice for anemia. This is also drug of choice for anemia associated with CKD. It is also drug of choice for anemia associated with CKD. So these are the medicines that are given for the recovery of the bone marrow. Now, when patients suffer from sickle cell anemia, we will give some disease modifying drugs. So which are the disease modifying drugs? So guys, please remember hydroxyurea. Hydroxyurea is a drug of choice for sickle cell anemia. We can also use L-glutamine. So L-glutamine is second disease modifying drug, and we have a medicine crizanlizumab. We have one more medicine, crizanlizumab. So crizanlizumab is a drug which is p-selectin protein inhibitor. It's a p-selectin protein inhibitor, crizanlizumab. It is also given for the treatment of sickle cell anemia. So there are three medicines which are used as a disease modifying drugs. So they are the disease modifying drugs which are given for the treatment of sickle cell anemia. One is hydroxyurea, L-glutamine, and crizanlizumab. So these medicines we use for sickle cell anemia. These are important for the exam. That is all about this topic, hematology. So guys, by mistake, I have given you some extra things which are not required. So by mistake, you people have got this PDF. So please ignore this. So these guidelines are for the higher level things like the DM level things, not for you people. So you can ignore this hypolip indications. This is all about hematology. Now, after hematology, guys, we can discuss the next topic, central nervous system. So if we talk about central nervous system, first topic, which is most important topic for NEET PG, that is anti-epileptic drugs. So if we talk about these medicines, which are anti-epileptic drugs, so patient can come to you with generalized seizure. So patient can come to you with generalized seizures, or patient can come to you with focal seizures. Now, the types of generalized seizures are GTCS, myoclonus, atonic, and the absence seizure. Right? Absence seizure, further of two types, typical and atypical. So, typical absence seizure is when the patient will have 3 Hertz frequency spikes. When the patient will have 3 Hertz frequency spikes in electroencephalogram, this is typical pattern. But atypical pattern means anything which is less than 2.5 is atypical. So 4 types of seizures are generalized seizures, GTCS, myoclonus, atonic, and absence seizure. And drug of choice for all this condition is sodium valproate. So sodium valproate is a drug of choice. Second drug of choice, if they will ask you, you can mark lamotrigine. So lamotrigine is a medicine that you can mark, but these days lamotrigine is avoided in patients of myoclonus. So these days lamotrigine is avoided in patients of only myoclonus. So in myoclonus, this is not a second drug of choice, but otherwise overall drug of choice is sodium valproate. So sodium valproate is drug of choice, second drug of choice lamotrigine. Now focal seizures can be of two types, simple focal, complex focal. Right? Now what is the drug of choice? So here the drug of choice is lamotrigine. If lamotrigine is not given in MCQ, you can mark carbamazepine and oxcarbazepine. So lamotrigine is the drug of choice. Other medicines are like oxcarbazepine, carbamazepine are the second drug of choice. Now guys, which medicine we can use for typical absence seizure? Now for typical absence seizures, you are supposed to mark ethosuximide. So ethosuximide is a drug which is an exclusive calcium channel blocker. This is a drug of choice. Second, you will mark sodium valproate. Second is sodium valproate. Third is lamotrigine. Right? So ethosuximide is a drug of choice, followed by sodium valproate and lamotrigine. This is for the typical absence seizure. Now, if we talk about some important guidelines which you should be knowing as a doctor for the antiepileptics, and these guidelines are after starting antiepileptics, what is the best time of withdrawal? So minimum 2 years of seizure-free interval. So when the patient will have minimum 2 years of seizure-free interval. So patient will have minimum 2 years of continuous seizure-free interval. Minimum 2 years of continuous seizure-free interval, then you can stop, you can think of withdrawing the therapy. And how to withdraw the therapy? The withdrawal should always be gradual. Take the time of 3 to 4 months. So this should always be gradual. Take the time of 3 to 4 months. This should not be abrupt. It should always be gradual. Right? But if the medicine is causing the side effect, you can stop it abruptly. You can stop the medicine abruptly, but because the risk of seizure is more, now here you can start other anti-epileptic drug. Here you can start other anti-epileptic drug in high dose. To stop the medicine abruptly and start the other anti-epileptic medicine in high dose. Now status epilepticus. In status epilepticus, wherever you have to stabilize the patient, you will give medicines by IV route like lorazepam. You can give the medicine by IV route, like you can give the drug lorazepam and diazepam. But if it is not available, then you can give intramuscular or nasal spray of midazolam. Right? So for status epilepticus, best medicine is lorazepam, followed by diazepam given by IV route. But if not available, then you can give intramuscular and nasal spray of midazolam. Now for maintenance treatment, you can give sodium valproate or you can give levetiracetam or fosphenytoin, right? So for maintenance treatment, you can give sodium valproate, levetiracetam, fosphenytoin. Out of these three, you have to give one. But if the seizures are not controlled by above medicine, that is considered as refractory case. Now for refractory case, okay, fine. The medicines which are given for maintenance treatment, they are given as IV bolus. They are given as IV bolus. But if the seizures are not controlled, it is refractory case, then you can give IV infusion. Then you can give IV infusion of propofol. You can give IV infusion of propofol or midazolam or the last option is phenobarbital. So these are the various options you have, right? So for stabilization, you have lorazepam, diazepam. For maintenance, you have valproate, levetiracetam, fosphenytoin, IV bolus. For refractory case, you have IV infusion for 48 hours, propofol, midazolam, or phenobarbital. This is for the status epilepticus. Now, guys, if we talk about the special population, if we talk about the special population like the pregnant female, nursing female, and the old patients. So, guys, in pregnant females, which medicines are safe? So, levetiracetam, lamotrigine, oxcarbazepine, carbamazepine, these medicines are safe, right? So, levetiracetam, lamotrigine, oxcarbazepine, carbamazepine are safe. So, these medicines are safe. Now, which medicines are highly unsafe? So, sodium valproate and phenytoin. Sodium valproate and phenytoin are unsafe medicines, right? And guys, please remember, if the female is pregnant, so in pregnancy, please remember, when the female has got pregnant and the seizures are not controlled, right? If the female is pregnant, she is taking some drug and the seizures are not controlled, you have to increase the dose. You have to increase the dose. And even after increasing the dose, the seizures are not controlled. So female is pregnant and her seizures are not getting controlled, you will increase the dose. And why you increase the dose? Because her volume of distribution is increased. But even after increasing the dose, her seizures are not controlled, then you have to change the drug. You have to change the drug and then you keep on doing like this way. You keep on doing like this way. When you change the drug, seizures are still not controlled, increase the dose, still not controlled, change the drug. Right? Guys, please remember, in pregnancy, never give two antiepileptic. So never give more than one antiepileptic drug together. So never give more than one antiepileptic medicines together. So do not give more than one antiepileptic medicines together in pregnancy. Now, immediately after delivery, you have to decrease the dose of the medicine. So immediately after delivery, you have to decrease the dose of the medicine. So you have increased the dose because the volume of distribution is increased. Now, immediately after delivery, you have to reduce the dose of the medicine because now her volume of distribution has been decreased. Volume of distribution has been decreased, right? So in pregnancy, initially we increase the dose if the disease is not getting controlled. If the disease is controlled, no need to do anything. Continue the same drug. But if the disease is not getting controlled, then only you will increase the dose, right? When immediately after delivery, you have to decrease the dose. Now, if we talk about the nursing female, now the medicines which were most unsafe in pregnancy become the most safe. So phenytoin and valproate are most safe medicines during the breastfeeding, and the medicines which were most safe in pregnancy become most unsafe. So levetiracetam, lamotrigine are unsafe. And if we talk about guidelines, maintain a time gap of minimum 3 hours. Maintain a time gap of minimum 3 hours between breastfeeding and the drug intake. Right? Now, if the patient is old, patient is having CKD, CLD, right, and the patient is on polytherapy, then there is a drug levetiracetam. We have a drug levetiracetam. Now, levetiracetam is a drug. This medicine has no drug interaction, and this is the drug which is safe to use in patients of CKD and CLD. Levetiracetam is a medicine which is safe to use in patients of CKD, CLD. Plus, this medicine has no drug interaction. So, in this special population, especially the old patients, levetiracetam is one of the very safe medicine to be used. So, levetiracetam is one of the very safe medicine to be used. This is for the special population. Now, this table is showing you the side effects of anti-epileptic drugs. So, we talk about the side effects of anti-epileptics, guys. So, side effects of anti-epileptics, I have discussed some important side effects. So, important side effects of medicines, like you can see, sodium valproate can cause maximum weight gain. Sodium valproate among all anti-epileptics cause maximum weight gain. Sodium valproate can inhibit the ovulation in females, can result in PCOD-like symptoms. PCOD-like symptom. This can damage the liver, can cause hyperammonemia, can result in encephalopathy. So, can result in hyperammonemia, encephalopathy. This can also cause thrombocytopenia, can result in pancreatitis and tremors as a side effect. When we talk about carbamazepine can cause cerebellar ataxia maximally. Apart from that, it can cause agranulocytosis, can result in SIDH. Because of SIDH, water is retained. When the water is retained, sodium get diluted. When the water is retained, sodium get diluted. This is for the SIADH. Now, this side effect is more commonly seen with oxcarbazepine. This side effect is more commonly seen with oxcarbazepine than carbamazepine, that is water retention and hyponatremia. Now, carbamazepine can also result in hypersensitivity reaction, especially in Indian population. Now, this is the drug which can precipitate myoclonus seizures as well as absence seizure. This medicine can result in myoclonus and the absence seizures in high dose. So in high dose, this medicine can cause myoclonus seizures and absence seizure. So carbamazepine is contraindicated. Carbamazepine is a contraindicated drug in myoclonus seizures and absence seizures. Now, phenytoin is a drug which will cause gum hypertrophy as one of the very common side effects. Now, this medicine can cause vitamin D deficiency. Medicine can cause vitamin D deficiency, can result in osteomalacia, can result in vitamin K deficiency, can result in bleeding as a side effect, can result in vitamin B9 deficiency. Now, vitamin B9 is folic acid, and as a result of that, this medicine can cause megaloblastic anemia. So, this medicine can cause megaloblastic anemia as a side effect. Now, the drug can also cause hirsutism, hyperglycemia, and phenytoin cannot control absence seizure. So, there is no rationale of starting this medicine in absence seizure. Now, topiramate is a drug which can cause weight loss. This medicine can cause formation of kidney stone, plus cause hyperchloremia, metabolic acidosis. So, these side effects you can read by yourself from these tables. Right? So, this is all about the side effects of antiepileptics. Now, let's talk about the sleep disorders. So, sleep disorders can be of two types. Sleep disorders can be of two types. One is insomnia, second is narcolepsy. Now, please remember, drug of choice for narcolepsy is modafinil. So, modafinil is a medicine which is a drug of choice for narcolepsy. But if there is a complicated narcolepsy, we also call it cataplexy. So, complicated narcolepsy is known as cataplexy. Now, the drug of choice for cataplexy is venlafaxine. So, venlafaxine is a drug of choice for complicated narcolepsy, that is cataplexy. Right? So, narcolepsy, we have modafinil, but there is a complication, cataplexy, we give venlafaxine. Now, for the insomnia, guys, please remember, drug of choice is zolpidem. So, zolpidem is a drug that will act on GABA A receptor. This will act on GABA A receptor and can result in increased chloride influx. So, zolpidem is a drug of choice. Now, whenever there is a toxicity of zolpidem, we have to give the antidote. The antidote is flumazenil. So, antidote is flumazenil. So, medicine antidote is flumazenil. And the important side effect of this medicine is associated with mild risk of addiction. So here there is a mild risk of addiction that is there, right? So if the patient has risk of addiction, then second drug of choice, orexin receptor antagonist are the second drug of choice. These medicines have no risk of addiction, so these medicines can be given to a patient. So if you find the patient will have the risk of addiction, I can give orexin receptor antagonist as a drug of choice. But otherwise, orexin receptor antagonist, like we have the medicine lemborexant. So lemborexant is overall the second drug of choice. Lemborexant is overall the second drug of choice for insomnia, right? So lemborexant is overall second drug of choice. But in patients who have addiction, we will prefer to use lemborexant as a drug. Now, benzodiazepine are the medicines that will also act on GABA A receptor, and their antidote is also flumazenil. So, benzodiazepine can be given for insomnia, but they should not be given for more than 14 days. So, these medicines should not be given continuously more than 14 days for insomnia. Otherwise, patient become addicted. So, addiction risk is there. Yes. So, Medico 1111. So, we have one more drug which is orexin receptor blocker, like Dr. Medico 1111 has answered. We call it suvorexant. But nowadays, lemborexant is better drug. Now, guys, we have the medicines which are melatonin receptor agonist. Now, these medicines maintain the sleep cycle. So, these medicines that will act on melatonin pathway, these medicines are given to maintain the sleep cycle. So, we have the medicine like Remeltion. We have the medicine like Remeltion, and we have one more drug like Agomelatine. So, Agomelatine and Remeltion are two medicines which belong to this class, which can maintain the sleep cycle. Now, they will act on melatonin receptors. These medicines will act on melatonin receptor. Now, apart from melatonin receptor, the drug name is agomelatine. This is also inhibitor of 5-HT2C receptor. So, by inhibiting this receptor, this medicine can increase the level of noradrenaline. This is an inhibitory receptor. 5-HT2C is an inhibitory receptor. So, when I block the inhibitory receptor, noradrenaline is increased. So this medicine has antidepressant property. So agomelatine is an important drug here, which has an antidepressant property, and this medicine can cause hepatotoxicity as an important side effect. So instead of Remeltion, guys, concentrate on agomelatine. This is a more important drug for the exam. So agomelatine has antidepressant property, and this medicine can cause hepatotoxicity as a side effect. Right? So it's a antidepressant, can result in hepatotoxicity as a side effect. Dr. Yashendra Sethi, Remeltion is not a first-line drug for insomnia. It cannot be, because Remeltion will not give you the sleep. Remeltion has a main role in maintenance of sleep cycle. Right. So agomelatine is antidepressant. Yes, Dr. Kaushiki, you can see it's an antidepressant medicine. Side effect is hepatotoxicity. Right. Now, if we talk about some important MCQs which are based on benzodiazepine, this you people can answer. Which is a short-acting benzodiazepine? Can you name a short-acting benzodiazepine? Agomelatine is an antidepressant. Yes, Kaushiki, it's an antidepressant. Which is a short-acting benzodiazepine, guys, which you people also have used in your hospital? Which one is a short-acting benzodiazepine that we use very commonly? That is midazolam. So midazolam is a drug that is very commonly used in daycare surgery, right? So midazolam is a drug which is a short-acting benzodiazepine, which is preferred in, right? Now, which drug is safe to use in chronic liver disease? So which benzodiazepines are safe to use in chronic liver disease? So in chronic liver disease, which two medicines are considered as liver okay benzodiazepines? So liver okay medicines are lorazepam. So L stands for lorazepam, O stands for oxazepam. So lorazepam, oxazepam are the liver okay medicine. Dr. Nirsevimab, I don't know this name that you have written, because my knowledge may be not that much appropriate, not up to date. Remimazolam, maybe some new drug have been launched. So I'm not saying midazolam is shortest, but I'm talking about a drug which is a short-acting benzodiazepine and very commonly used in India. Although we have 5 or 6 medicines, which are shorter acting, but midazolam is very commonly used in India. One of the very commonly used short-acting medicine in India is midazolam. So liver okay medicines are lorazepam, oxazepam. Now, what is a drug of choice for alcohol withdrawal syndrome? So which benzodiazepine is drug of choice for alcohol withdrawal syndrome? Drug name is chlordiazepoxide. So chlordiazepoxide is a drug of choice for alcohol withdrawal syndrome. Now the benzodiazepine which has muscle relaxant property, that is diazepam. So guys, please remember, diazepam is a medicine. It's the only benzodiazepine which has a muscle relaxant property. So muscle relaxant benzodiazepine is diazepam. Alcohol withdrawal syndrome, chlordiazepoxide. Safe to use in liver disease, lorazepam and oxazepam. These are the MCQs that can be asked on benzodiazepine. Now guys, let's talk about the neuralgia. So if we talk about neuralgia, so which medicine we can use for diabetic neuropathy? So for treatment of diabetic neuropathy, guys, Duloxetine, which is an antidepressant medicine. This is an antidepressant medicine. This is a drug of choice, right? And in case this is not available, the alternative of this is amitriptyline. Alternative of this is amitriptyline, which is also an antidepressant medicines. So for the diabetic neuralgia, we give duloxetine or amitriptyline. In case these antidepressants are not able to control, we have to move on to the second drug of choice. And the second drug of choice are known as gabapentinoids. We call them pregabalin and gabapentin. So we have two medicines like pregabalin and gabapentin. So pregabalin, gabapentin, these medicines are known as gabapentinoids. So we can give gabapentinoids to our patients, which is pregabalin better than gabapentin. Now, medicines which are given for trigeminal neuralgia. So drug that is given for trigeminal neuralgia. So here we have the medicine like carbamazepine and oxcarbamazepine. So carbamazepine, oxcarbamazepine can be used, but there is a doubt regarding the drug pregabalin. So pregabalin can be tried, like pregabalin or gabapentin can be tried, right? But the utility is doubtful in trigeminal neuralgia. Now for post-spinal injury neuropathy, we give antidepressants again. So antidepressants like amitriptyline. This is a drug of choice. Now for post-herpetic neuralgia, guys, again antidepressants. Antidepressants are the drug of choice. Like amitriptyline belongs to TCA, so any of the TCA we can use. So post-herpetic neuralgia, TCA medicines are drug of choice. If not controlled, we can move on to the second drug of choice, that is gabapentinoids. So gabapentinoids can be given as a second drug of choice, right? So this is the answer of all the neuralgias. So neuralgias we people have discussed here. After this neuralgia, we have some medicines antipsychotic. Guys, now this topic antipsychotic is less relevant for your NEET PG. For NEET PG, they don't ask psychiatry medicines much, but in INLCT, they are very fond of asking psychiatry drugs. So be careful. Like you can save your time when you're going for the NEET PG, but you have to spend time here more in case you are going for the INLCT exam. So antipsychotics can be of two types, typical, atypical. We also call them first generation, second generation. First generation, second generation antipsychotic. Now the first generation medicines are only blocker of dopamine pathway, but the second generation medicines are blocker of two pathways, mainly serotonin, second dopamine. So these medicines are mainly blocker of dopamine pathway, but second generations are blocker of both serotonin and the dopamine pathway. But guys, apart from that, these medicines are also inhibitor of 5-HT2C receptor. So by inhibiting 5-HT2C receptor, they can increase the level of noradrenaline. So they also have mild antidepressant property. So although they are antipsychotic, you can see from here, although they are antipsychotic, but these second generation medicines also have antidepressant property. And because of this antidepressant property, they can control the psychotic mood, they can control the depressive mood. So they are the wonderful mood stabilizer. They can stabilize the patient mood. The mood will not fluctuate in any direction because they have mild antidepressant property. So here we have the medicines like aripiprazole, cariprazine, clozapine, lurasidone. So please remember guys, aripiprazole is a drug when given to a patient. Apart from inhibiting 5-HT2 receptor, this is a partial agonist of D2 receptor. It has a different mechanism. Instead of blocking D2, it's a partial agonist of D2 receptor. If we talk about cariprazine instead, apart from blocking 5-HT2 receptor, this is the D3 receptor agonist. Now if we talk about clozapine is a drug which is blocker of 5-HT2 receptor, but after that it blocks D4 receptor, then it blocks D2 and D1 almost equally. It blocks D2 and D1 receptor almost equally, but here the most important is D4. Now guys, lurasidone is a drug which is a medicine which is a wonderful mood stabilizer. This is the drug which is one of the best mood stabilizer available here. The drug name is lurasidone. So all these are special drugs that you must be knowing. So aripiprazole, cariprazine, clozapine, lurasidone. There is one more drug, guys, I forgot to mention over here. The medicine name is pymavanserin. We have one more drug, pymavanserin. Now, pymavanserin is also a unique medicine here, which is only 5-HT2 blocker. This medicine has no action on dopamine pathway. It is only 5-HT2 blocker. So these are the 5 drugs that you should be knowing. Their mechanisms are important. They can be asked as MCQ because they have the different something. So what is the different thing? We can see aripiprazole. The different thing is it is dopamine agonist. Cariprazine is D3 agonist. Clozapine is D4 blocker. And pymavanserin has no dopamine blocking effect. Lurasidone is the best mood stabilizer available here. Right? Now, guys, these medicines are given for the treatment of schizophrenia mania, which are the psychotic disorder. And please remember clozapine. Clozapine is a drug. It is considered as drug of choice for refractory schizophrenia. It is the best medicine for refractory cases of schizophrenia. It is the best medicine to control negative symptoms. Negative symptoms of schizophrenia, best controlled by clozapine. After clozapine, it is best controlled by cariprazine. So negative symptoms, best controlled by best controlled by clozapine. After that, it is controlled by cariprazine. And this is the only drug. This is the only drug which can control suicides. Right? This is the only drug which can control suicides in psychosis. So 3 important MCQs. Clozapine is a drug of choice for refractory schizophrenia. It is the best medicine for negative symptoms of schizophrenia, followed by cariprazine. And this is the only drug which can control suicides in psychosis. Next is route of administration. So guys, here we have a medicine. Here we can give the medicines by intramuscular depot form. And we have to follow a technique. We call it Z-track technique. So these medicines are given with the help of Z-track technique. And there is a medicine over here, acinapine. Acinapine is a drug which is given in the form of sublingual tablet. This is the fastest acting drug. This is the fastest acting antipsychotic medicine, acinapine. And this is given in acute emergency when the patient is having the tendency for the self-harm. So patient has tendency for self-harm. Patient has self-harm tendency. Then we can use acinapine as a fastest acting medicine over here. Now, if we talk about the medicines elimination, so please remember all antipsychotics. You want me to go a little faster, Dr. SP, or slower? I think. So if we talk about elimination, all medicines dose need to be decreased in patients of liver disease. So all antipsychotic dose need to be decreased in liver disease except paliperidone. So paliperidone is the drug which is purely eliminated by kidney. So this is the drug that is safe to use in patients of liver disease. So paliperidone is the only drug which is safe to use in patients of liver disease. Okay, I'll go a bit fast. Right? Now let's talk about medicines common side effects. So if we talk about medicines common side effects, now these medicines can block the D2 receptor, and by blocking the dopamine pathway, the medicines can cause extrapyramidal symptoms and hyperprolactinemia. Medicines can block histamine receptor, can cause sedation and drowsiness. Medicines can block this histamine receptor plus the serotonin 2C receptor, can result in metabolic complication like weight gain and diabetes mellitus. Medicines block alpha-1 receptor, can cause hypotension. Medicines block muscarinic receptor, can cause anticholinergic side effect, can cause QT prolongation, result in arrhythmia, torsades de pointes, result in seizures and sexual dysfunction as a side effect. So these are the common side effects of the medicines that we have covered. Now, in typical drugs, maximum dopamine blocking side effect caused by haloperidol, minimum of the side effect caused by chlorpromazine and thioridazole. Minimum of the side effect caused by chlorpromazine and thioridazole. But if we talk about other side effects in typical drugs, they are maximally caused by chlorpromazine and thioridazole. Right? But all other side effects are minimally caused by haloperidol. All other side effects are minimally caused by haloperidol. And these first generation medicines, typical antipsychotic, they will not cause seizures and sexual dysfunction. They will not cause seizures and sexual dysfunction as a side effect. But if we talk about atypical medicines means second generation antipsychotics, maximum of dopamine blocking side effect caused by risperidone. So risperidone will cause maximum extrapyramidal symptoms and hyperprolactinemia. Now minimum it is caused by clozapine. Minimum it is caused by clozapine, aripiprazole. So minimally caused by clozapine, aripiprazole, quetiapine. So minimally caused by quetiapine, olanzapine. So these are the drugs that will cause minimum of the side effect like clozapine, aripiprazole, quetiapine, olanzapine, iloperidone. These medicines will cause minimum. If we talk about histamine blocking side effect, now histamine blocking side effect or sedation drowsiness maximally caused by clozapine, minimally caused by pymavanserin. It is minimally caused by pymavanserin. Now the metabolic complication maximally caused by clozapine, second maximum by olanzapine. Maximum by clozapine, second maximum by olanzapine. This is minimally caused by ziprasidone. Guys, please highlight this point because this is one of the prospective MCQ this year. Right? So this is a NEET PG 2024 question. Right? So ziprasidone will cause minimum weight gain. Minimum weight gain caused by ziprasidone. This is a important MCQ for this year exam. Now, alpha blocking side effect maximally caused by clozapine. Maximum anticholinergic side effect caused by clozapine, but this is minimally caused by aripiprazole. This is minimally caused by aripiprazole. Right? Now, QT prolongation is maximally caused by ziprasidone. Seizures maximally caused by clozapine. Sexual dysfunction maximally caused by clozapine. So this here we don't have the studies. Here we don't have the minimum studies available, so we cannot say which drug will cause minimum. We don't have the studies available. Now guys, if we talk about the unique side effects, in unique side effect, clozapine is important drug here. Now, clozapine can cause unique side effect as cyalorrhea and epilepsy. Now whenever this medicine will cause cyalorrhea as a side effect, now for cyalorrhea we can give glycopyrrolate. So its unique side effect as cyalorrhea that is managed by glycopyrrolate. And epilepsy is managed by giving the anti-epileptic drug like lorazepam or benzodiazepine. Now, there are two important side effects caused by clozapine which require monitoring. So, two side effects which require monitoring. One is known as myocarditis, second is known as agranulocytosis. Now, myocarditis is a dose-related side effect. It is seen when the medicine plasma concentration will cross 350 nanogram per ml. When the medicine plasma concentration will cross more than 350 nanogram per ml, then this side effect will appear. And how we monitor the side effect? We monitor the side effect by CPK level and troponin level. So we monitor the side effect of the medicine by CPK level and by the troponin level. And what is the management? The management is we have to decrease the dose of the medicine. Now, if we talk about agranulocytosis, it's an autoimmune side effect. So it has no relation with the dose. So it has no relation with the dose. It's an autoimmune side effect. Now, this is monitored by, so if we talk about its monitoring is done by absolute neutrophil count. Monitoring is done by absolute neutrophil count, and you have to stop the clozapine. You have to stop the clozapine permanently if the absolute neutrophil count will go below 500. So stop the clozapine when the absolute neutrophil count will go below 500. Now, the medicines can cause extrapyramidal symptoms. These medicines can cause extrapyramidal symptoms. Now, there are four types of extrapyramidal symptoms: muscle dystonia, Parkinsonism, akathisia, and tardive dyskinesia. So, guys, symptoms you will cover in your psychiatry class. How this side effects are presented, this is covered in your psychiatry class. Now, if we talk about the treatment part, if we talk about the treatment, so guys, please remember for the treatment of muscle dystonia and Parkinsonism, if the question is asked to you how we prevent the first two side effects. So first two side effects are best prevented by giving benzhexol or benztropine. So prevention is by oral drugs like benzhexol and benztropine. If it is not given in MCQ, you will give promethazine. So promethazine is given as a second drug for prevention. But if if the patient has come to you with acute symptoms, if the patient has come to you with acute symptoms, now for acute symptoms, we will give medicine by IV route, that is promethazine. So promethazine is given by IV route for these symptoms. So promethazine is given by IV route to control the acute symptoms. Now, akathisia. Akathisia is best controlled by propranolol. It is not an emergency. This is managed by tablet propranolol. And tardive dyskinesia is best controlled by giving the medicines like valbenazine. This is best controlled by giving medicines which are VMAT inhibitors. Medicines which are VMAT inhibitors, which are also known as dopamine depleters. So here we have a drug valbenazine. So valbenazine is a medicine. This is given as a drug of choice for tardive dyskinesia. Right? This is all about extrapyramidal symptoms. Now guys, let's talk about antidepressants. So if we talk about antidepressant medicines, these are of three types. We have the typical antidepressants medicines like SSRIs, SNRIs, and tricyclic antidepressants. So typical antidepressants are SSRIs, SNRIs, and TCA. And all these medicines can lead to a common side effect as sexual dysfunction. All these medicines have common side effect as sexual dysfunction. But if we talk about atypical medicines, they will not cause sexual dysfunction as a side effect. They will not cause sexual dysfunction as a side effect. We call them atypical antidepressant medicine. So here we have the medicine bupropion. Here we have the medicine bupropion. This medicine is also given for nicotine de-addiction. This is also given for nicotine de-addiction. This is also given for obesity. And one of the important side effects of this medicine is seizures. One of the important side effects of medicine is seizures. Right? Number two, there is a drug mirtazapine. So mirtazapine is an atypical antidepressant which will not cause sexual dysfunction. And this medicine has one more important point, that this is the drug which has no drug interaction. This is the antidepressant which has no drug interaction. And the third medicine we people have already covered, agomelatine. So agomelatine will act on melatonin receptor, and the important side effect is hepatotoxicity. This we people have already covered. So these are the three medicines which are atypical antidepressant medicines. Atypical antidepressants, we have the medicine bupropion, mirtazapine, and agomelatine. The hallmark is they will not cause sexual dysfunction. Now let's talk about the medicines which are serotonin modulators. The serotonin modulators are the medicines, they will also cause sexual dysfunction. So these medicines can also cause sexual dysfunction as a side effect. They will also cause sexual dysfunction as a side effect. So this is the difference between serotonin modulators and atypical medicines. So here the medicines names are like trazodone. Here the medicines are like trazodone. Right? So trazodone, important side effect is priapism. Important side effect is priapism. Second medicine here is nefazodone. Now nefazodone is a drug which can cause hepatotoxicity. This can cause hepatotoxicity as a side effect. Now the third medicine is vilazodone. So we have the medicines like trazodone, nefazodone, vilazodone, and we have one more drug, vortioxetine. So vortioxetine is one more medicine which belongs to this class. Now vortioxetine is an antidepressant which can improve the patient cognition. So this can improve the patient cognition. The drug name is vortioxetine, and the side effect of vortioxetine is nausea. So nausea is a big issue that we are facing when we give vortioxetine to a patient. Patient complain of nausea, and because of that, compliance is getting an issue. So vortioxetine can improve the patient cognition. It's the only antidepressant which can improve the cognition, but the important side effect is nausea caused by this medicine. So vortioxetine side effect is nausea. So medicines here are vilazodone, vortioxetine, nefazodone, and trazodone. So if we talk about typical medicines in detail, so if we talk about typical drugs, we have three medicines which are typical antidepressant drugs: SSRIs, SNRIs, and TCA. So guys, please remember, SSRIs will increase serotonin, SNRIs will increase both serotonin and noradrenaline, and TCA drugs will mainly increase noradrenaline, and second effect is serotonin. Right? Now SSRIs are the one which are which are drug of choice for all type of depression. and all type of anxiety disorders. So all type of anxiety disorders, all type of depression, SSRIs are the drug of choice. They are the drug of choice for all type of anxiety, all type of depression. They are also drug of choice for fibromyalgia. They are also drug of choice for premature ejaculation in males. The drug of choice for premature ejaculation in males, particularly paroxetine. So paroxetine is a drug which is a wonderful drug for the treatment of premature ejaculation in males. Now, if we talk about SNRIs, they have the same indications as SSRIs. They have the same indications as SSRIs except premature ejaculation. So they have the same indications as SSRIs except premature ejaculation. Apart from that, we have already covered. They are also given for diabetic neuralgia like duloxetine. So duloxetine is a drug of choice for diabetic neuralgia. They are also drug of choice for stress incontinence. Also drug of choice for stress incontinence. So duloxetine is drug of choice for stress incontinence, drug of choice for diabetic neuralgia. Right. Apart from that, we have covered that venlafaxine. Venlafaxine is drug of choice for cataplexy. It's a drug of choice for cataplexy. Right. And if we talk about TCA drugs, TCA medicines have same indications as SNRIs, and we have already covered they are the drug of choice for post-herpetic neuralgia. They are the drug of choice for post-herpetic neuralgia. They are also drug of choice for post-spinal injury neuropathy. So post-spinal injury neuropathy. So post-spinal injury neuropathy, they are the drug of choice. We have covered all these points. If we talk about guys their elimination, these medicines are metabolized by liver. These are eliminated by kidney, and these are also metabolized by liver. So the medicines metabolized by liver, they have the drug interaction, but there is no drug interaction with SNRIs, and SSRIs also have the drug interaction. But there is one drug over here which does not have the drug interaction. Drug is escitalopram. So escitalopram is a drug here which does not have the drug interaction. Now guys, if we talk about their duration of action, if we talk about their duration of action, so if we talk about their duration of action, then we'll say all these medicines are long acting. So all these antidepressants are long acting medicines, but there are some exception to this rule. Like here the exceptions are fluvoxamine. So here the exceptions are fluvoxamine and the paroxetine. So these two medicines are shorter acting. Here the exception is venlafaxine. Here the exception is venlafaxine. Here the exception is amoxapine. Amoxapine is the exception to the long-acting medicines. Right? Now, in pregnancy, these medicines are safe except paroxetine. So paroxetine is a drug when given to pregnant female can result in congenital heart disease. Can result in congenital heart disease in fetus. Can result in congenital heart disease in fetus. Otherwise, these medicines are safe. Now, SNRIs are the medicines which are also proved to be safe, and TCA medicines are also safe. So all antidepressants are safe except paroxetine, which is unsafe and contraindicated because this medicine can cause congenital heart disease. Now guys, we have discussed the names of 4 medicines which are shorter acting. Now these shorter acting medicines, if you stop or if you will skip the dose, if you skip the dose of this medicine, so if you skip the dose of this medicine for 1 or 2 days, you can have the recurrence of symptoms. You can have the recurrence of symptoms that is known as discontinuation syndrome. So discontinuation syndrome is the recurrence of symptoms. So patient will have the recurrence of symptoms if you skip 1 or 2 doses of short-acting medicine. So if you skip 1 or 2 doses of short-acting medicine, patient can have the discontinuation syndrome as a side effect. So guys, if we talk about the medicine side effects, so SSRI side effects, you can remember with the mnemonic go SSRIs. So medicine side effects are go SSRIs. So these medicines can cause GIT side effect as the most common side effect. These medicines can also cause osteoporosis. Drugs can cause osteoporosis due to hyponatremia. These medicines can also cause serotonin syndrome. Medicines can cause serotonin syndrome. These medicines can cause sexual dysfunction. Medicine can cause sexual dysfunction as the second most common side effect. Now, these medicines can cause recurrence of symptoms. Medicines can cause recurrence of symptoms, especially if we talk about the shorter acting medicine. Plus, these medicines can also cause insomnia as a side effect. So, medicine side effects are GAT side effects, osteoporosis, serotonin syndrome, sexual dysfunction, recurrence of symptoms, and medicines can cause insomnia. If we talk about SNRIs, these medicines will also increase the serotonin, so side effects are same as Go SSRIs. Go SSRIs is the same side effects. Plus, these medicines can also increase the level of noradrenaline. So, these medicines can lead to sympathetic side effects. Medicines can result in sympathetic side effect. Now, if we talk about tricyclic antidepressants can cause side effects, which we can remember with the mnemonic SHAMA. Right? So, medicine side effect is SHAMA, where the medicines can cause sexual dysfunction that we have already covered. Medicines can cause seizures. Medicines can block the histamine receptor, so can result in sedation and drowsiness, can result in weight gain, can result in sedation, drowsiness, and weight gain. Now, these medicines can block the alpha 1 receptor, can cause hypotension, block the muscarinic receptor, so result in anticholinergic side effect. Plus, these medicines can cause arrhythmia. These medicines can also cause arrhythmia. Right, guys? So, during the toxicity of this medicine, patient can have, so if we talk about TCA toxicity, so during the medicine toxicity, patient can have the same acute symptoms like SHAMA, plus patient can have the metabolic acidosis. Patient can have the metabolic acidosis during the toxicity. So we have to give the antidote, and the antidote of TCA toxicity is sodium bicarbonate. So sodium bicarbonate is the antidote of TCA toxicity. So TCA toxicity, the antidote of choice is sodium bicarbonate. So this is what we people have already covered during our lecture, right? So we have covered this atypical antidepressants before that, so that we have already covered. So let's move on to the bipolar disorder. So guys, if you people have covered these things in psychiatry, we can leave. So we talk about bipolar disorder. So in bipolar disorder, when the patient will have the acute symptoms, like the patient has come to you with acute mania. For acute mania, treatment of choice is sodium valproate. So sodium valproate, if not available, you will go for lithium. Now this combination is given along with second generation antipsychotics. So guys, if you remember, second generation antipsychotics are the wonderful mood stabilizers. So we give valproate followed by lithium as a first or the second drug of choice. Along with that, we will give second generation antipsychotic like lurasidone. So lurasidone can be given. Now for hypomania, drug of choice, treatment of choice, only second generation antipsychotics. Now for depression, we will give, for depression, if the patient will have the mild symptoms, we will give only second generation antipsychotic like lurasidone. But if the patient is having moderate to severe symptoms, then we have to give SSRIs plus second generation antipsychotic. So we have to give second generation antipsychotics along with SSRIs because now the symptoms are severe. So they have the antidepressant property. I told you second generation antipsychotics have antidepressant property. So for mild symptoms, they can manage. But for moderate to severe symptoms, we have to give these medicines along with SSRIs. So this is the treatment that we give for depression, acute mania, acute hypomania. Now if we talk about maintenance treatment of bipolar disorder. So guys, in non-pregnant patients, lithium is a drug of choice. Second generation antipsychotics or atypical antipsychotics are the second drug of choice. But if the patient is pregnant, this sequence gets reversed because lithium, when given to pregnant female, can result in Epstein's anomaly. So because of the risk of Epstein's anomaly, second generation antipsychotics are better than lithium. Now in CKD patients, only second generation antipsychotics are used. Lithium is contraindicated. So in CKD patient, lithium is contraindicated. And when the patient has tendency to commit suicide, only lithium is a drug that is useful. So in suicidal tendency cases, only lithium is a medicine that can control. Right? So this is for the bipolar disorder. Now, if we talk about this medicine, lithium, if you talk about this lithium, guys, you must be knowing body cannot differentiate between which two ions. So body cannot differentiate between which two ions? Lithium and sodium. So body cannot differentiate between lithium and sodium. So lithium is a less lipid soluble drug. This will take slow entry in CNS. Right? So this medicine has slow onset of action. This has slow onset of action because this will take slow entry in CNS. Now, the medicine half-life is approximately 1 day. Medicine half-life is approximately 1 day, that is 24 hours. Right? And its steady state level, medicine's steady state level will be achieved after 4 to 5 days. Steady state level of the medicine is achieved after 4 to 5 half-life, 4 to 5 days. Right? Now, after achieving the steady state, if we change the dose, then we have to wait for minimum 12 hours. We have to wait for minimum 12 hours to take out the next plasma sample. Now, which fluid is the best fluid for monitoring of lithium? That is plasma. So plasma is the best fluid for monitoring. After that, we can also use urine dipstick test. The urine dipstick test can also be used. Now, which medicines can cause toxicity? So guys, any drug that will cause hyponatremia, like diuretics, like AC inhibitors and ARB. So these medicines can cause toxicity. NSAIDs can cause toxicity. Dehydration, whenever dehydration occurs, this will cause toxicity. Now, which medicine are protective? Which medicines can cause treatment failure? So guys, please remember, mannitol is a drug that will cause treatment failure. One more is amiloride. So amiloride is a protective medicine. This is the protective drug. Amiloride is a protective drug. Mannitol is one more drug that will remove the lithium from the body and can lead to treatment failure. Right? Now, if we talk about the important side effect of lithium, we can remember with a mnemonic, that is lithium itself. So the mnemonic is lithium itself. So this medicine can increase leukocytes. This medicine can increase WBC. This medicine can cause fine tremors. Medicine can cause fine tremors as the most common side effect. Now, this medicine can cause 3 hormonal problems. This medicine can cause 3 hormonal problems. This can inhibit antidiuretic hormone. This can cause hypothyroidism and can result in hyperparathyroidism. Due to hyperparathyroidism, calcium level is increased. Now, this medicine can lead to increased weight. So, medicine can cause weight gain, and medicine can result in appearance of U wave in ECG. This medicine can result in appearance of U wave in ECG, and when given to pregnant females or mother, this will cause Epstein's anomaly. Now, for the toxicity, the treatment of choice. Treatment of choice for toxicity is IV fluids. So IV fluids is a treatment of choice for toxicity, but hemodialysis can also be done. Hemodialysis can also be done when the serum lithium level is more than 3 milliequivalent per liter, or the patient is having CKD, or the patient is getting life-threatening symptoms. Patient is having CKD or the lithium level more than 3, we can also go for hemodialysis. So we can go for hemodialysis. Right? Guys, one thing I forgot to mention, lithium is a drug that is only given by oral route. Lithium is the medicine that is given only by oral route, and the most common form of lithium is lithium carbonate. So lithium carbonate is the most common form of lithium that we use. Now guys, after that we have the opioids. Now opioids are the medicines which are used as a painkillers. Now these medicines can act at the level of spinal cord as well as act at the level of brain. So brain means supraspinal, right? So in spinal cord, In spinal cord, these medicines can be given by extradural route. Medicine can be given by subarachnoid route. Medicines can be given by subarachnoid route and extradural route. Right? Now, we have the receptors, that is mu, most common, followed by kappa and then delta. So in spinal cord, we have the mu, kappa and delta receptors present in the dorsal horn. Present in dorsal horn, substantia gelatinosa. Present in substantia gelatinosa layer. So present in substantia gelatinosa, mu, kappa and delta receptors. Right, guys? Now the side effect is, advantage of using is higher centers. Higher centers are not affected. So whenever we give medicine by spinal cord, higher centers are not affected. So respiration is not suppressed. So the only side effect reported by this route is pruritus. So only side effect is pruritus that can be noticed. Now for supraspinal effect, medicines are given by systemic route. So medicines are given by systemic route for the supraspinal effect. Now in brain, we have the receptors like mu, kappa and delta is almost negligible. Delta is almost negligible. They are present mainly in the pain center. They are mainly present in the pain center, and in pain center, they will activate the descending pain pathways and used as a painkiller. Now, the important side effect is they can suppress the higher centers. They can suppress the higher center. Plus, even by this route, the medicines can cause pruritus as a side effect. Can result in pruritus as a side effect. So these are the wonderful painkillers. We call them opioids. They are drug of choice for cancer pain. Now guys, apart from that, we have some other properties. Like guys, you must be knowing, morphine is also given for acute CHF. Morphine is also given for acute CHF. Right guys? Apart from that guys, please remember, morphine is a drug which can release histamine. This can release histamine in the body. So should not be given to a patient of bronchial asthma and should not be given to a patient of hypotension. Should not be given to a patient of bronchial asthma and hypotension. Medicine can suppress the respiratory center, so should not be given in patients of head injury. So in patients of head injury, should not be given in patients of head injury because this will suppress the respiratory center. If we talk about the medicine, methadone. Now, methadone is given for opioid de-addiction. So apart from painkiller, it is given for opioid de-addiction. The drug name is methadone. Now, one of the important side effect of methadone is QT prolongation. The medicine has very fast onset of action. It will take only 30 minutes. And side effect is QT prolongation. If we talk about meperidine, now meperidine is a drug that is given for the treatment of colicky pain. This is very good drug for the treatment of colicky pain. The drug name is pethidine. Now, please remember guys, in CKD patient, in patients of CKD, pethidine and morphine, these two medicines are contraindicated. So pethidine and morphine are two medicines which are contraindicated. Otherwise, these medicines in CKD patients can result in seizures as a side effect. So can result in seizures as a side effect in patients of CKD. Now we have the medicine sufentanil. This is the most potent opioid available in the market. It will act on all three receptors, mu, kappa and delta. Remifentanil is the shortest acting opioid available in the market. Now, fentanyl is a drug which can be given by multiple routes of administration. And L-fentanyl is a drug which is available in the form of skin patch. So these are the important features of all these points. Loperamide is an opioid. It's a drug of choice for non-infective diarrhea. It's a drug of choice for non-infective diarrhea. And this is the medicine which cannot cross blood-brain barrier. Now, propoxyphene is the least potent opioid. It's a least potent opioid available in the market, propoxyphene. Now, the medicines which are partially agonist, buprenorphine. Now, buprenorphine is partially agonist at mu receptor. This is a low ceiling opioid. It can be useful for opioid de-addiction. It is given for opioid de-addiction. It is the longest acting. It is the longest acting opioid available in the market. And naloxone, which is an antidote of all opioids, cannot be used for buprenorphine poisoning. Naloxone cannot be given for buprenorphine poisoning. Now, codeine is a drug which is used as a cough suppressant, and after liver metabolism by CYP2D6 enzyme, this is converted to morphine, and then it is used as an analgesic drug. It is used as an analgesic drug. Now we have some mixed action drugs, which are the low ceiling drugs, bitorphenol, nalbuphine, and pentazocine. One of the important side effects of pentazocine is tachycardia. Now, tramadol and tapentadol are the medicines. They will act on the mu receptor. Apart from that, they will also increase the level of serotonin and the noradrenaline in brain. So they are the reuptake inhibitors. They are the reuptake inhibitors of noradrenaline and serotonin in our brain. And accordingly, they can cause side effects like serotonin syndrome and can result in sympathetic side effect. Now, dextromethorphan is a drug which is a drug of choice for dry cough. This is a drug of choice for dry cough. The drug name is dextromethorphan. Right? Now, guys, we have some medicines which are full antagonist. Now, naloxone is a drug of choice for opioid toxicity. This is a fast-acting medicine, drug of choice for opioid toxicity. Now, naltrexone is drug of choice for prevention of relapse. This is a drug of choice for prevention of relapse in opioid as well as alcohol. So, in opioid and alcohol de-addiction, this is the drug of choice to prevent the relapse. Now, methyl naltrexone and LV-Mopane are the medicines which cannot cross blood-brain barrier. So they will not act on central nervous system. They cannot cross blood-brain barrier. They will only block mu receptor in periphery, and they are given for the treatment of opioid-induced constipation. They are given for the treatment of opioid-induced constipation. So in treatment of opioid-induced constipation, we can use these medicines like methyl naltrexone and LV-Mopane. Right, guys? After that, guys, we have the topic of opioid drug de-addiction. Now, this topic is already covered in your psychiatry class. So, this topic is already covered in your psychiatry. So, there is no point of discussing because you people have already discussed over there. So, in case you people have any doubt in drug addiction, you can ask, right? Now, next topic is Parkinson's disease. Now, in patients of Parkinson's disease, the patient will have the dopamine deficiency. Patient can have the dopamine deficiency. So for mild symptoms patients, the drug of choice is MAO-B inhibitors. So MAO-B inhibitor like selegiline. Selegiline is a drug of choice. Now for patients who have the moderate symptoms, less than 60 years of age, drug of choice is dopamine 2 receptor agonist like pramipexole and ropinirole. So pramipexole and ropinirole. Now, the patients who are more than 60 years of age, here the drug of choice is levodopa. Here the drug of choice is levodopa. Now, for patients who have the severe symptoms, whether the age is 60 or more than 60, less than 60, does not matter. Here the drug of choice is levodopa. Drug of choice is levodopa. Now, next is restless leg syndrome. So in restless leg syndrome, first of all, you will check the serum ferritin level. So if the serum ferritin level is low, iron supplement is the treatment of choice. But if serum ferritin level is normal and patient is not obese, patient has no tendency for drug abuse, and patient has no history of critical work, then gabapentinoids. So gabapentinoids like pregabalin and gabapentin. So pregabalin, gabapentin will be the drug of choice. But if any of the condition is present, like the patient is obese, patient is drug addict, patient is involved in some critical work where you don't want the sedation, then in that case you will mark drug of choice as dopamine 2 receptor agonist. Right? So if the patient is obese, patient has drug addict property or drug addict risk of drug addiction, or patient is involved in some critical work where you cannot afford sedation, then you mark gabapentinoids. But if any of the thing is present, you will mark dopamine 2 receptor agonist. This is for the restless leg syndrome. This is all about central nervous system. The central nervous system, guys, we people have covered. Okay, now which topic you want to cover after that? So after CNS, let's talk about antimicrobial drugs. Achha, Parkinsonism you want to discuss again. So Parkinsonism, mild symptoms, you will give MAO-B inhibitor selegiline, which also has antioxidant property. Moderate symptoms, less than 60 years, you will give dopamine 2 receptor agonist pramipexole ropinirole. More than 60 years, you will give levodopa. Severe symptoms, again you will give levodopa. Next is antimicrobials. So if we talk about this topic, antimicrobials. Now in antimicrobials, the first topic is antibiotics. So one MCQ can be asked from this classification of antibiotic. This is important. So the medicines which are cell wall inhibitors, medicines which are bacterial cell wall inhibitors, medicines are beta lactams. Medicines are beta lactams. So medicines are penicillins. Medicines are penicillins. Medicines are cephalosporins. Medicines are carbapenims and monobactams. So we have the medicines which are beta lactam antibiotics like penicillin, cephalosporin, carbapenims and monobactams. Now beta lactams are inhibitor of penicillin binding protein. They inhibit penicillin binding protein in bacteria and inhibit the cell wall. Now we have the glycopeptide antibiotic like vancomycin. So vancomycin is the drug which is inhibitor of transglycosylase enzyme. This is inhibitor of transglycosylase enzyme in bacterial cell wall and inhibit the bacterial cell wall. Now we have a drug fosfomycin. Now fosfomycin is also cell wall inhibitor and this is the medicine that we can use for the treatment of UTI. Fosfomycin is given for UTI. Now this is the drug which is safe to use in pregnancy for UTI. This is safe to use in pregnancy for UTI. Now after that guys, we have the medicines like cell membrane inhibitors. So medicines which are cell membrane inhibitors, these medicines are like colistin and daptomycin. So colistin and daptomycin are cell membrane inhibitors. Medicines which are protein synthesis inhibitors. So protein synthesis inhibitors, medicines that will act on 30S ribosome. So medicines that will act on 30S ribosome, medicines are aminoglycosides and tetracyclines. So aminoglycosides, tetracyclines will act on 30S. Medicines which will act on 50S, medicines are like macrolides. So macrolides will act on 50S ribosome. Linezolid will act on 50S ribosome. So linezolid, macrolides, clindamycin. Clindamycin, streptogramins. These medicines will act on 50S ribosome. Right? They will act on 50S ribosome. Now the medicines which are folic acid pathway inhibitor. So here we have a drug cotrimoxazole. Here we have a antibiotic cotrimoxazole. So cotrimoxazole is a folic acid pathway inhibitor. Now we have the medicine that will inhibitor of nuclear material. So we have the fluoroquinolones which are DNA gyrase inhibitor. So fluoroquinolones are DNA gyrase inhibitors. Rifampicin is RNA polymerase inhibitor. Rifampicin is RNA polymerase inhibitor. We have the medicine like metronidazole, nitrofurantoin. So metronidazole, nitrofurantoin, they are the direct DNA inhibitors. They are the direct DNA inhibitor. So this is the classification of antibiotics. So after the antibiotic classification, we can discuss their pharmacokinetics. So if we talk about antibiotic pharmacokinetics, now guys, all medicines are eliminated by kidney. All medicines are eliminated by kidney except few medicines. So all medicines are eliminated by kidney except few medicines which are metabolized by liver. So which antibiotics are metabolized by liver? So those are safe to use in CKD patients. Like we have some beta lactam antibiotics. So we have some beta lactam antibiotics which are safe to use in CKD because they are metabolized by liver. Like we have the drug neficillin. So neficillin is a medicine that is metabolized by liver. We have a medicine like cefoperazone. So cefoperazone, neficillin and ceftriaxone. So cefoperazone, ceftriaxone, neficillin. Now guys, we have two tetracyclines which are metabolized by liver. One is doxycycline, one is tigecycline. We have two fluoroquinolones like moxifloxacin, and pefloxacin. So moxifloxacin, pefloxacin. And we have the medicines protein synthesis inhibitor that will act on 50S ribosome. So protein synthesis inhibitor that will act on 50S ribosome. So these antibiotics are safe to use in CKD. So these antibiotics are safe to use in CKD. Rest of the medicines we have to reduce in patients of CKD. After this pharmacokinetics, we can discuss the medicine specific features. So guys, please remember, whenever we give penicillin G along with propionic acid, so this can reduce the penicillin G elimination. This can reduce the penicillin G elimination and can lead to more action of penicillin G in the body. Now, imipenem when given with cilastatin. So cilastatin can inhibit the metabolism. Cilastatin can inhibit the metabolism of imipenem and can prolong the action of imipenem. Now guys, there is a drug cefoperazone. Cefoperazone is a cephalosporin which can inhibit this vitamin K oxidoreductase enzyme, which is also inhibited by warfarin, and therefore this medicine can cause bleeding as a side effect. So this medicine can cause bleeding as a side effect. Drug name is cefoperazone. Now, if we talk about fluoroquinolone pharmacokinetics, there are two fluoroquinolones which have 100% oral bioavailability. One is known as levofloxacin, second is known as ofloxacin. They have 100% oral bioavailability, right? Now, these fluoroquinolones can interact with cation containing drugs. So they can interact with calcium tablets, iron tablets. They can interact with antacids. So always maintain a time gap. Always maintain a time gap of 120 minutes. Always maintain a time gap of 120 minutes between fluoroquinolones and the antacids or any drug which contains cation. Now here we have a drug ciprofloxacin. Ciprofloxacin is a liver enzyme inhibitor and can inhibit theophylline metabolism. So this medicine can inhibit theophylline metabolism. Ciprofloxacin is a liver enzyme inhibitor. In pregnancy and in children, in pregnant females and in children, these medicines can cause tendon and cartilage problem. So these medicines can cause interfere with the growth of tendon and cartilage. So medicine can interfere with the growth of tendon and cartilage in pregnancy and in children. Now tetracyclines can bind with calcium, interfere with the growth of bones and teeth. Interfere with the growth of bones and teeth. So should not be given to pregnant female and should not be given to children. Should not be given to children less than 7 to 8 years of age. Now we have the medicines like cotrimoxazole. So cotrimoxazole is a drug which is combination of two drugs, trimethoprim plus sulfamethoxazole in ratio 1:5. In ratio 1:5. So all these are important points in pharmacokinetics of antibiotics. After that, we can discuss medicines pharmacodynamics. So in pharmacodynamics, guys, please remember the medicines which are cell wall inhibitors, medicines which are cell membrane inhibitors that we discussed above, and the medicines that will act on nuclear material. Medicines that will act on nuclear material, these medicines are generally bactericidal drugs. And the medicines which are protein synthesis inhibitor that you can see from above, and the medicines which are folic acid pathway inhibitors, these medicines are generally bacteriostatic, but there are some exceptions. Exceptions here are like aminoglycosides. So aminoglycosides, cotrimoxazole, and streptogramins. So aminoglycosides, cotrimoxazole, and streptogramins are the three medicines. Although they are protein synthesis inhibitor or folic acid pathway inhibitors, but these medicines are not bacteriostatic, they are bactericidal. So these medicines are bactericidal, they are not bacteriostatic drugs. Aminoglycosides, cotrimoxazole, streptogramins. Now if we talk about pattern of bacterial inhibition, so there are three patterns. One is known as time-dependent killing. Second is known as concentration-dependent killing. So medicines which follow time-dependent killing, these medicines are penicillins. So penicillins follow time-dependent killing. Cephalosporin generation 1 and 2. Cephalosporin generation 1 and 2 follow this type of killing or pattern of inhibition. time-dependent killing, vancomycin, erythromycin, and tetracycline. So these are the 5-6 medicines which follow time-dependent killing. Now, medicines which follow concentration-dependent killing, these medicines are aminoglycosides. So aminoglycosides, doxycycline, azithromycin, daptomycin, and we have a new drug, tadizolid. So these are the medicines which follow concentration-dependent killing. Now we have some medicines which have the pattern, we call it area under the curve. Now guys, please remember the drugs which follow time-dependent killing, these medicines are preferably given in multiple low dose. These medicines are given in multiple low dose. The medicines which follow concentration-dependent killing, these medicines are preferably given in single high dose. So medicines which follow concentration-dependent killing, they are given in single high dose, and the medicines which follow time-dependent killing, they are given in multiple low dose. But we have some medicines that can be given in any pattern. So these medicines can be given in any pattern. They can be given in a single high dose, can be given in multiple low dose. So these medicines follow a pattern, we call it area under the curve. So these drugs are like fluoroquinolone. We have one more example like clarithromycin. So clarithromycin, fluoroquinolone, which follow under this category, which follow any pattern of inhibition. So they follow any pattern. They can be given in any pattern. They are not required to be given in multiple low dose or single high dose. After that, guys, we have the antibiotic combinations. So antibiotic combination can be synergistic, can be antagonistic. Now, this is antagonistic when you combine a static antibiotic with a cidal. So when you combine static antibiotic with the cidal, this is antagonism. It is synergistic. In synergistic, we have additive. Now, additive means 1 plus 1 become 2. 1 plus 1 become 2. Like in antagonistic, 1 plus 1 become less than 1. This is antagonistic. Now, additive is 1 plus 1 become 2. Now, this is possible. This is possible like static plus static. Static plus static, or also possible with cidal plus cidal. Now, supra-additive is also known as drug potentiation. This is known as drug potentiation. We also call it supra-additive. We also call it drug potentiation. Now, drug potentiation means the one drug is active against bacteria, the other drug is not active against bacteria. So the overall effect will be more than one. Overall effect will be more than one. One example is like amoxiclav. Second example is like piptaz. So one example amoxiclav, second example piptaz. This is a supra-additive effect. This is a supra-additive effect. Drug potentiation we call it. Right? Yes, Dr. Nishchay, penicillin is given in single dose. You are saying many, like syphilis it is given. So guys, that penicillin is a different form. Like that is a benzathine penicillin. That action lasts for 21 days. So you can modify the antibiotic, then you can give in any pattern. But if I'm talking about the plain penicillin, that is given, that need to be given in multiple low dose. Okay, guys. So resistance, bacterial resistance. So bacteria can activate the resistance against the antibiotic. So the one method of resistance is beta lactamase. Now everybody is saying, sir, go faster. When I started the lecture, everybody was saying, sir, go slower. Why this change? Why this paradigm shift? So enzyme production is the most common method of resistance where the bacteria can produce beta lactamase enzyme. So guys, when Staph aureus can produce beta lactamase, we can use the medicine against Staph aureus, which we can remember with the mnemonic, that is condom. So we can use the medicine like cloxacillin. We can use the medicine like oxacillin. We can use the medicine like neficillin. We can use the medicine like dicloxacillin. So these are the medicines like cloxacillin, oxacillin, neficillin, dicloxacillin. They are the drug of choice for beta lactamase producing Staph aureus. But guys, when other bacteria started producing the medicine, we discovered when other bacteria started producing the medicine, when other bacteria started producing, let's give me 1 minute. There is some technical. When other bacteria started producing, we people discovered enzyme inhibitor like clavulanic acid. So we started combining beta lactamase inhibitor. Now, in gram-negative Klebsiella, bacteria started producing beta lactamase that is known as ESBL, extended spectrum beta lactamase. Now, the drug of choice for extended spectrum beta lactamase is carbapenems. We give carbapenems. So, drug of choice, carbapenems. When the bacteria started producing metallozyme, which is also known as superbug. This is also known as superbug, metallozyme, or we also call it New Delhi virus. So here the drug of choice is colistin. Here the drug of choice is colistin. The second one is tigecycline. When the bacteria started producing AMPC, so here the drug of choice is generation 4 cephalosporins. Generation 4 cephalosporins are the drug of choice. Now, guys, the second method of resistance is target modification. When the bacteria has become MRSA, methicillin resistant Staph aureus, so here the penicillin binding protein is modified. So penicillin binding protein is modified. So there is a ointment muprosin. Ointment is muprosin. This is a drug of choice for carrier state. This is a drug of choice for carrier state against muprosin. Now, there is an oral antibiotic linezolid that can be used very commonly. Cotrimoxazole is one more oral antibiotic can be used against MRSA. But there is an IV antibiotic vancomycin which is overall a drug of choice. So vancomycin is overall drug of choice for MRSA, but there is an ointment muprosin. This is given for carrier state. Now when the bacteria is vancomycin resistant Staph aureus, here we give daptomycin as a drug of choice. Here we can give daptomycin as a drug of choice. And for the bacteria which is vancomycin resistant enterococcus, most commonly used medicine is linezolid. So most commonly used medicine against vancomycin resistant enterococcus is linezolid. Now guys, after that we have the indications of antibiotics. So guys, here you have to just mug up the names of the bacteria. So nothing to teach over here. You have to just remember the names of the bacteria where the medicines are drug of choice. So these are the 5 groups of antibiotic I have chosen where the questions have been asked in last 5 or 10 years. So guys, please remember the indications of only these 5 group of antibiotics. So these 5 group of antibiotics, the indications are important. So just remember the names of the bacteria where these antibiotics are a drug of choice. The only thing you have to do is this. Now after the indications, we can discuss other things. So we can go a bit fast now. So empirical treatment में, like if any question based on meningitis, if empirical treatment, if any question based on meningitis and the patient is immunocompetent, the patient age is less than 55 years, patient is immunocompetent, suffering from meningitis, you will mark generation 3 and 4 cephalosporin with vancomycin as a treatment of choice. But if the patient age is more than 55 years, in the above treatment, you will add ampicillin. In the above treatment, you will add ampicillin to cover the bacteria that is listeria. Now, when the patient is immunocompromised, or the patient has history of neurosurgery or the road traffic accident, now here you will give generation 4 cephalosporin, you will not give generation 3, plus you will give vancomycin, plus you will also give ampicillin. This is for the meningitis. When the MCQ is based on skin infection, right, you will find whether the abscess is present or not present. So if the abscess is not present, you can mark any of the drug that we have covered above in mnemonic of condom, or you can mark cephalexin. Cephalexin is generation 1 cephalosporin, or you can also mark amoxiclav, or the fourth option is you can mark cotrimoxazole. So these are the four medicines. These are the four medicines that are given for the skin infection: amoxiclav, cotrimoxazole, cephalexin, or condom. Condom group of antibiotic like cloxacillin, oxacillin, neficillin. But if the patient is having the abscess, you can give any of these beta-lactam. You can give any of this beta-lactam to the patient with whatever we have discussed on the left side. Along with that, you will give metronidazole to cover anaerobic bacteria. Or we only give clindamycin. For the skin infection where we have the presence of abscess. Now, the third case, we can ask you, the patient comes to you with UTI. So any patient who will come to you with UTI, so the UTI is uncomplicated when the kidney is not involved. Complicated means kidney is involved. So when the kidney is not involved, it is uncomplicated. So here you can mark fosfomycin. Here you can give fosfomycin, or you can give nitrofurantoin. Or you can give cotrimoxazole. So these are the three answers you can mark as per your requirement. But if the patient is having the complicated UTI, so in complicated UTI, you can mark generation 3 cephalosporin. You can give generation 3 cephalosporin, or you can give amoxiclav. Generation 3 cephalosporin, or we can also give fluoroquinolones. So fluoroquinolones we can use for complicated UTI. So complicated UTI, we can give generation 3 cephalosporin, amoxiclav, and fluoroquinolones. टूट गया डॉक्टर कॉलेज 6 लैब कॉली डॉक्टर टूट गया निमोनिया okay lab coli doctor pneumonia mein which drug will you give in pneumonia which medicine will you give so pneumonia mein if the patient has come to an OPD or the patient is admitted in hospital if the patient has come to an OPD and patient has no comorbidity then you will give amoxiclav along with amoxiclav you will give doxy or azithro. Out of these two, one medicine is given. Now, when the patient has come to an OPD with comorbidity, right? So patient has come to you with comorbidity, then you will give beta-lactam, that can be amoxiclav or can be generation 3 cephalosporin. Along with that, you will give doxy. Along with this, you will give doxy. Or there is one more option. You can give respiratory fluoroquinolones. When the patient is admitted in hospital, patient is admitted in non-ICU ward, then you will give beta-lactam that we have covered over here. Along with that, you will give respiratory fluoroquinolone. Patient is admitted in ICU, so same treatment is given, but the medicine should have anti-pseudomonal property. In ICU patients. So this is how we manage a patient of pneumonia. Now, after pneumonia, there is a prophylactic antibiotic of choice. So for meningococcal infection, we can use ciprofloxacin. Second is rifampicin. So ciprofloxacin, rifampicin is prophylactic antibiotic of choice for meningococcus. H. influenza meningitis, rifampicin is a drug of choice. For diphtheria, erythromycin. Erythromycin is a drug of choice. For plague, doxycycline is a drug of choice. For leptospira, doxycycline is a drug of choice. So these are the 5 bacterial disease where we give the prophylaxis. 5 bacterial disorders where we give the prophylaxis. Now, the next is antibiotic side effects and their management. So, side effects of antibiotic and their management. So, if we talk about antibiotic side effect and their management, first is beta-lactams. So beta-lactams can cause hypersensitivity reaction. So you have to replace beta-lactam antibiotics with some oral antibiotic like macrolide. You can give macrolide or you can also give cotrimoxazole. You can also give cotrimoxazole. And whenever you have to give medicine by IV route, here you can give vancomycin or you can give sulfamethoxazole. You can give sulfamethoxazole. Now, beta-lactam antibiotics can also cause pseudomembranous colitis. So here the drug of choice is fidaxomicin. If fidaxomicin is not given, you can go for vancomycin. Now, medicine which will cause bleeding as a side effect that we have already covered. Drug name is cefoperazone. Cefoperazone can cause bleeding as a side effect. Now, seizures caused by imipenem. Seizures caused by imipenem and cefepime. Cefepime and imipenem are two medicines which can cause seizures as a side effect. Now, if we talk about aminoglycosides can cause side effect like nephrotoxicity, ototoxicity, neuromuscular junction blocking effect, and in pregnancy, they are contraindicated. Now, these are the side effects of linezolid, which you can remember with the mnemonic BSNL line. So here the line stands for linezolid, B stands for bone marrow suppression, S stands for serotonin syndrome, N stands for neuropathy, and L stands for lactic acidosis. Now, fluoroquinolone side effects are they can interfere with the tendon and the cartilage growth. They can cause neurotoxicity and can cause artery dissection as a side effect. This is all about antibiotics. So antibiotics we people have covered. Now guys, antifungal I have given you the full 100% notes. For antifungal I have given you the 100% notes. In case you people have any doubt, please ask. Right? So you can read these notes by yourself. So the medicines are like pollines. So pollines are the drugs which can form pores in the cell membrane. So these medicines can form pores in the cell membrane. So the medicines names are like nystatin and natamycin. So nystatin and natamycin, they are given by local route for the treatment. They are given for local route, but the important point is they cannot be given for skin infection. They are only given for mucosal infection. Now we have one more drug that is choline. We call it liposomal amphotericin B. This is a drug of choice for cryptococcal meningitis, where it is given along with flucytosine. So 5-FC means flucytosine. Now it is also drug of choice for mucormycosis, where it is given along with posaconazole. Also, it is drug of choice for all serious fungal infection, except coccidial meningitis and invasive aspergillosis, where it is a second drug of choice. So in these two conditions, coccidial meningitis and invasive aspergillosis, it is a second drug of choice, but it is a drug of choice for all other serious infection, including the visceral leishmaniasis. Now, medicine side effect is nephrotoxicity that we can prevent by giving the IV fluids like normal saline. Other side effects are electrolyte disturbances, ototoxicity, and hypersensitivity reactions. If we talk about the second group of medicines, medicines is elylamine. The medicine name is terbinafine. So terbinafine is a drug which is squalene epoxidase enzyme inhibitor, and it is mainly given for the treatment of tinea infection. Side effect is hepatotoxicity. Right, guys? Similarly, guys, we have the medicines like azoles. Azoles mechanism of action, they can inhibit 14-alpha demethylase enzyme, inhibit ergosterol synthesis. Now, in acidic media, these medicines are better absorbed. These medicines are better absorbed in acidic media, so they are contraindicated to be given along with PPIs and histamine blocker. So they should not be given with medicines which are anti-acidic drugs. So they are required acidic media for absorption. Now these drugs are liver enzyme inhibitors, right? Now all medicines are eliminated mainly by liver, but fluconazole is a drug. This is eliminated by kidney. So fluconazole is a drug which is eliminated here by kidney. Now, posaconazole is a drug which is mainly eliminated in feces. This is mainly eliminated in feces, right? Now, we have a drug over here, isavuconazole. Isavuconazole is a prodrug. Now, spectrum we have discussed here. Fluconazole has a narrow spectrum. Isavuconazole has a broadest spectrum. And accordingly, we have the medicines. We have written the indications. Like fluconazole is a drug of choice for Candida albicans, Cryptococcus, and coccidial meningitis, as well as it is drug of choice for tinea versicolor. It's a drug of choice for tinea versicolor. Itraconazole is drug of choice for most of the tinea infection as well as endemic fungal infection. Voriconazole, drug of choice for aspergillosis, and posaconazole is given for the treatment of mucormycosis along with lymphosomal amphotericin B. So in this way, guys, you can read these topics here for your examination point of view. This is important. Echinocandidates. Now, guys, echinocandidates are the medicines which are given exclusively by IV route. They are given by IV route, first MCQ. These are the antifungals which are inhibitor of cell wall, second MCQ. How they inhibit cell wall? They inhibit beta-glucan synthase enzyme, third MCQ. Fourth MCQ, they are given for all species of Candida. They are given for all species of Candida. They are given for all species of Candida, plus they are also given for aspergillosis. Now, guys, the problem of echinocandidates is it is given by, these medicines are given by IV route. Now, Ibraxa fungirap we have discovered. This is given by oral route. So, very, very important MCQ for this year exam. Ibraxa fungirap can be given for all species of Candida, but it is given by oral route. Right? So, this is all about a brief introduction about antifungals. Similarly, guys, we have given the leave this Candida HIV drugs. So, we have given you the details of HIV drugs also. Right? So in case you can read these medicines by yourself. Okay, so there are a few names which are missing that I will cover, I will fulfill for you. So if we talk about medicines like NRTI, nucleoside reverse transcriptase inhibitors, they are eliminated by kidney. Important side effects are lipodystrophy, peripheral neuropathy, and pancreatitis. Now, these side effects are minimally seen with the drug that is lamivudine. So, lamivudine is a drug that will cause minimum of this side effect. Now, megaloblastic anemia and nail bed pigmentation. This is caused by a drug zidovudine. Now, pigmentation of palms. This side effect is caused by emtricitabine. So, emtricitabine will cause this side effect. Now, hypersensitivity reaction is caused by abacavir. Now, if we talk about the second class, NNRTIs, these medicines are metabolized by liver. Another common side effect is hypersensitivity reaction. Now, here the hepatotoxicity is caused by nevirapine. CNS toxicity is caused by efavirenz. CNS toxicity is caused by efavirenz. Now, integrase inhibitors. Now, integrase inhibitor, here the important drug is dolutegravir. Now, dolutegravir can cause weight gain. This medicine can cause insomnia. Medicine can cause weight gain, insomnia, and can result in hepatotoxicity. Can result in hepatotoxicity. Now, if we talk about protease inhibitors, so protease inhibitors, common side effect. Common side effect is lipodystrophy except atazanavir. So atazanavir is a drug that will not cause lipodystrophy. Atazanavir will not cause lipodystrophy. Now renal stone is a side effect that is caused by indinavir. So renal stone is a side effect caused by indinavir. Now hyperbilirubinemia is a side effect caused by indinavir again, as well as caused by atazanavir. This is also caused by atazanavir. Now the side effect is bleeding. Now bleeding is a side effect that is caused by tipranavir. So this side effect is caused by tipranavir. Now for COVID-19, we can use the medicine like remdesivir. It's a RNA polymerase inhibitor. For swine flu, we use oseltamivir. We use oseltamivir as a drug of choice. It is a neuraminidase enzyme inhibitor. Now we have a endonuclease enzyme inhibitor. The drug name is baloxavir. Drug name is baloxavir. Now for hepatitis B, DNA polymerase inhibitors are drug of choice. Drug of choice is tenofovir. तो डॉक्टर विशाल का कॉपी भर गया. डॉक्टर विशाल कॉपी पे लिखना भी नहीं था ना. I'll share this PDF with you. You have to just recall, like when I'm teaching, you have to just recall the drug name. So because ultimately you will get this PDF. So I am your servant. I am doing the work for you. Acha Vishal, tell me. For herpes virus, DNA polymerase inhibitor is a drug of choice. What is the name of the drug? Vishal, what is the drug of choice for herpes virus? Have you ever got a herpes virus? HSV1, HSV2, anywhere in your body? If you got herpes virus ever? Okay, yes, this is acyclovir. Acyclovir is a drug of choice. And if virus is refractory to acyclovir, we can use a medicine like cidofovir and foscarnet. So foscarnet, cidofovir are the medicines that we can use. This is all about antiviral, all about antimicrobials. So we have covered antifungal, antiviral, and antibiotics here. Now in antiprotozoal, you have to read the anti-malarial PSM program. So anti-malarial PSM program is important. Otherwise, the rest of the drugs are not important. Right, guys? So we have covered this antimicrobial. Now, which topic, guys, we want to cover? We left with two major topics. One is endocrine, second is general pharma. So which topic you want to cover? General pharma or endocrine? Yeah, you people are tired, must be tired. Okay, let's choose the selected topics like endocrine. You want to go general pharma first. Okay, general pharma. Let's start with general pharma. Okay, now start answering general pharma. So in general pharma, guys, the first topic is drug absorption. So in drug absorption, bioavailability. Bioavailability of a drug is calculated by area under the curve. Bioavailability of a drug is calculated by area under the curve. And what are the various factors that will decide the drug absorption? So what are the various factors that will decide the drug absorption? So if the drug is lipid soluble, drug has more bioavailability, drug has more absorption. If the size of the molecule of the drug is less, again the drug can easily cross the membrane, drug has more bioavailability. If the surface area on which you have kept the medicine is more, the medicine has more rate of absorption. Medicine is absorbed at a faster speed. Now, if the vascularity is more, then again the rate of absorption is more. Now, if you take medicine after having the food, then the medicine rate of absorption gets slowed down. Now, guys, if the GIT motility is more, then please remember rate of absorption of drug is more. Rate of absorption of drug is more. But if the patient has the GIT disease, the absorption of the drug will go down. Now, if the medicine has high first pass metabolism, then what will happen to the bioavailability, guys? This you people have to answer. FPM means first pass metabolism. Now, in the pH of media, guys, please remember, like is absorbed in like media. Like is absorbed in like media means acidic drugs are absorbed in acidic media. So acidic drugs are absorbed from upper part of GIT and basic drugs are absorbed from lower part of GIT. So acidic drug from upper part of GIT, but in upper part of GIT, they are better absorbed in duodenum than the stomach. And in lower part of GIT, they are better absorbed in ileum than the colon. Yes. So if the medicine has more bioavailability, overall medicine has more first pass metabolism, overall bioavailability is low. So these are the 8 points that will decide how much drug is going to be absorbed. After that, guys, we have the drug distribution. Now in drug distribution, we calculate the volume of distribution. Now from this volume of distribution formula, that is dose upon plasma concentration, we can say dose of a drug. Dose of a drug depends upon volume of distribution and plasma concentration. So dose of any drug depends upon volume of distribution and the plasma concentration. Now, which factors volume of distribution depends? So guys, very simple. If a patient body size is more, If the patient body has more compartments, the size is more, compartments are more, that patient has more volume of distribution. So you need to give more dose to that patient. So any patient who has more volume of distribution, more body size, more compartments in the body, that patient requires more dose. So there are some physiological factors like pregnancy, obesity, patient has more body surface area, adult patient in comparison to a child. So these are the patients who have more volume of distribution in their body. So they require more dose. Similarly, some pathological states like edema, liver disease patient is having the ascites, patient is having the congestive heart failure. So these patients have hypervolemia. So these patients have hypervolemia, so their volume of distribution is more, they require more dose. But if the patient has dehydration, patient is on fasting, volume of distribution will decrease, so patient require less dose. Now, some factors which are related to drugs. If a drug is more lipid soluble, then the medicine can easily take entry in organs. Medicine can easily take entry in organs. And when the medicine will take entry in organs, medicine volume of distribution is more. Medicine volume of distribution is more. And when the medicine is more plasma protein bound, if a medicine is more plasma protein bound, then the size of the drug molecule, is more. When the size of the drug molecule is more, guys, what will happen to volume of distribution? This you people have to answer me. The size of the drug molecule become more because of plasma protein binding. What will happen to the volume of distribution? So answer is volume of distribution will increase or decrease. If anyone who is awake right now, yes, answer is the volume of distribution will decrease. So volume of distribution will decrease. Now guys, in human body, the normal water content is 42 liter. So if any medicine, normal water content is 42 liter. If any medicine has volume of distribution more than 42 liter, if any medicine in the patient body has volume distribution more than 42 liter, it means medicine is more lipid soluble. Medicine has taken more entry in organs. It means medicine has taken more entry in organs. Medicine is more distributed. You can say anything like medicine has more distribution, medicine has more organ entry, medicine is more lipid soluble, or you can say medicine is less plasma protein bound. So anything you can say depends on the question. If the medicine volume of distribution is more than 42 liter, the medicine volume of distribution less than 42 liter, everything is opposite. Now the third is drug targets. If we talk about different types of drug targets, we have the receptors. The most common target of the medicine. The most common target of the medicine is receptors. So guys, where we have the nuclear receptors. So if we talk about the nuclear receptors, so the mnemonic is TAPE. So thyroid hormone has nuclear receptor. Vitamin A has nuclear receptor. PPAR gamma, PPAR alpha are nuclear receptors. And estrogen has nuclear receptors. So these are the four things that have the nuclear structure. They have the receptors present in nucleus. Now, if we talk about cytoplasmic receptors, so guys, please remember all steroids, right? All sex hormones. So all steroids, all sex hormones, that includes estrogen again. So estrogen has the receptor at 2 location and vitamin D. So they have the receptors in cytoplasm. Now the membrane receptor having the kinase activity. Right? So we have insulin and the growth factors. Insulins and the growth factors in the body. So insulins and growth factor, they are associated with tyrosine kinase activity. But if we talk about prolactin, if we talk about leptin, if we talk about cytokines, right? Cytokines, leptins, prolactins, and growth hormones. They have the membrane receptors with Janus kinase activity. So they have the Janus kinase activity, prolactin, leptin, cytokines, and growth hormones. They have the Janus kinase activity. Now the membrane receptors having the G protein coupled receptor. So whatever is not covered here, all other drugs All other drugs will act on G protein coupled receptor, which is a 7 helical shape structure. So this receptor has 7 helical shape. This has a 7 helical shape receptor, G protein coupled receptor. Now here the inactive form of the receptor, G protein coupled receptor, when it is present in inactive form, we call it GDP. And when it becomes active, this is known as GTP. So when it becomes active, we call it GTP. When it is inactive, we call it GTP. So these are the different types of receptors that can be asked in your exams in this topic of drug targets. Now guys, after these drug targets, we have the drug actions. Now whenever we talk about drug actions, we have to calculate the log DRC. We have to draw this graph, that is log DRC, right? So here the dose is plotted in logarithm scale. So logarithm scale advantage is, what is the advantage of plotting the medicine dose in logarithm scale? Wide range of dose. So wide range of dose can be plotted. So wide range of dose can be plotted if we take the logarithm scale. So if we take the logarithm scale of the on the x-axis of the dose, we can say wide range of dose can be plotted. This is the advantage of the logarithm scale. Guys, who will tell me if I say the middle part of this DRC? If I say the middle part of the DRC is a straight line, then what is the advantage? The advantage is the calculations. Calculation of drug response. Calculation of drug response is very easy. So the advantage is calculation of drug response is very easy. So if the middle part is a straight line, we can say calculation of drug response is very easy. Right? Now, who will tell me what is therapeutic index of a drug? If you can see this graph, if I say this is the LD50 and this is the ED50. If I say this is the LD50 and ED50, when 50% of your sample, when the 50% of your sample will die, this is LD50. And when 50% of your sample will show you the response, that is ED50. So effective dose 50 and lethal dose 50. So when 50% of the sample will die, this is LD50. And when 50% of your sample will respond to the treatment, 50% of the sample respond to the treatment is ED50. Yes. So therapeutic index is calculated when we divide LD50 upon ED50. This is the index of safety. This is the index of safety. Now guys, what is therapeutic range? So if we talk about therapeutic range, the therapeutic range is, this is from minimum effective concentration to minimum toxic concentration. So minimum effective concentration to minimum toxic concentration. So what is minimum effective concentration? When most of the sample show you the response. When most of the sample show you the response, this is minimum effective concentration. And what is minimum toxic concentration? When most of the samples do not show toxicity. When most of the sample do not show toxicity, right? Like in this graph, if I draw, I want that most of the sample will show me the response. So this is MEC, and I want that most of my sample will not show the toxicity. Then I will say this is MEC, right? This is MEC. So here I have dose 1, here I have dose 2. So you can see dose 2 is greater than dose 1. So I will say this dose 1 to dose 2 is my therapeutic range dose. So I will always try to give more than dose 1. I will always try to keep less than dose 2. I always try to give more than dose 1. I will always try to give less than dose 2. This is my MEC, minimum effective concentration, and minimum minimum toxic concentration. So when I able to calculate these concentrations, accordingly, I will come to know about the dose. And when I know the about dose, I will always keep the medicine range in this dose. This is a therapeutic range. Now, guys, we can also see the potency. Now, who will tell me out of these four graphs, which is most potent? So whenever we have to comment upon potency, Pani piyo. Ashutosh, Red Bull. So A is most potent. A is most potent, then B, then C, then D. So one very simple rule in potency, left side DRC. Any medicine which has left side DRC, that is more potent. Any medicine that has right side DRC, that is less potent. Now guys, if we talk about efficacy, who will tell me? In this graph, the most efficacious is C, then B, then A. And in this right side graph, who will tell me what is the sequence of drug? So in efficacy, guys, height of DRC is important. So more is the height of DRC. More is the height of DRC, more is the efficacy. Less is the height of DRC, less is the efficacy. So here the D followed by A, then we have C, then we have B. So we have D, A, C, B. This is how we comment upon the efficacy. So height of the DRC is important. Right? Now this graph is showing you the tolerance, that is known as inverted U-shaped graph. This is inverted U-shaped graph. This is showing you the drug tolerance. The last is slope. Now slope will tell you about the risk of toxicity. Slope will tell you about the risk of toxicity on increasing the dose. So slope will tell you about the risk of toxicity on increasing the dose. You can see if the medicine has steep slope. If the medicine has steep slope, then the minor increase in the dose. Minor increase in the dose on x-axis. You can see there is a major change in the response on the y-axis. So here the risk of toxicity is more. So here the risk of toxicity is more. But if you talk about the flat slope, you can see minor increase in the dose will not increase in the response. The response will not increase much. So in the flat slope, the risk of toxicity is less. Here the risk of toxicity is less. Now, whenever there is a presence of competitive and non-competitive blocker in the body, so in the presence of competitive blocker, DRC is shifted towards right side. So right shift of DRC means presence of competitive blocker. And in non-competitive blocker, we say that there is a flattening of DRC. You can see flattening of DRC means non-competitive blocker. You can see the drug is same A. Here also the drug is same A. But when there is a flattening of dose response curve, it means there is a non-competitive blocker. But if there is a right shift of curve, we call it competitive blocker. This is all about the DRC. So guys, in drug metabolism, you people have to cover liver enzyme inducers and inhibitor list. You people have to remember. So in case you don't have the list, I can share it with you later on. But right now we don't have the time to discuss the list of medicines which are inducers and inhibitors. Now finally, guys, we have the drug elimination. If we talk about the drug elimination, first is net elimination of the drug. So if we talk about the net elimination of the drug from the kidney, this is equal to filtration plus secretion minus reabsorption. So filtration plus secretion minus reabsorption. Now filtration will take place through glomerulus. Filtration will take place through glomerulus. Now this depends upon kidney blood flow. So more is the kidney blood flow, more is the filtration. Less is the kidney blood flow, less is the filtration. It also depends upon plasma protein binding. It also depends upon plasma protein binding. So more is the plasma protein binding, more is the size of the drug molecule, then less is the filtration. So more is the plasma protein binding, more is the size, less is the filtration. Now elimination also depends upon how much drug is secreted directly in PCT of kidney. So tubular secretion will take place in PCT of kidney. Now this is possible with the help of ATP pumps. This is possible with the help of ATP pump. Now the reabsorption of the medicine will take place from the late portions of tubule. So from late portions of tubule, reabsorption of the drug will take place. So please remember, if the drug is lipid soluble, the reabsorption is more and therefore the elimination is less. If the drug is lipid soluble, reabsorption is more. It means the medicine elimination is less. And it also depends upon pH of urine. So we know that like is absorbed in like media. We know the concept like is absorbed in like media. So in case the drug which has entered in GFR, the drug that has entered in GFR, if that drug is acidic and urine is acidic, the drug will be reabsorbed and the elimination will reduce. Drug is reabsorbed and elimination is reduced. And guys, vice versa is also true. If your drug is acidic and you want to remove that medicine, you don't want that medicine should come back. You don't want that medicine should come back and the medicine should get eliminated out of the body. You want that medicine should get eliminated out of the body. So you have to do the forced alkaline diuresis. A forced alkaline diuresis can be done for acidic drug poisoning. This is done for acidic drug poisoning. So this is the treatment of choice for aspirin toxicity. This is treatment of choice for methotrexate toxicity as well as phenobarbital toxicity. So phenobarbital toxicity, aspirin toxicity, methotrexate toxicity, we can go for forced alkaline diuresis. We can make the urine alkaline by giving sodium bicarbonate to the patient. So when we give sodium bicarbonate to the patient, we can make the urine alkaline and now the acidic drugs can be eliminated out of the body. Now guys, question is asked on clearance. Clearance is nothing, just a rate of elimination upon plasma concentration. What is T half? T half is natural log of 2 divided by K. Now this can be rewritten as 0.693 divided by K. Now this can rewritten as 0.693 volume of distribution upon clearance. This is the half-life of the medicine. So K is elimination constant. K is elimination constant, right? Last is steady state level of the drug. The steady state level of the drug will be achieved after 4 to 5 half-life. Steady state level of the drug will be achieved after 4 to 5 half-life. After 4 to 5 half-life, what will happen? Rate of elimination of the drug. Rate of elimination of the drug, which is clearance multiplied by the plasma concentration, becomes equal to the rate of absorption of drug. So rate of absorption of drug is dose multiplied by the bioavailability divided by the dosing interval. So here the dosing interval you can write like 24 hours if you're giving medicine OD. You can write 12 hours if you're giving the medicine BD. So this is the equation of the steady state level. This is the equation of the steady state level. Now guys, loading dose is calculated when we multiply volume of distribution and plasma concentration. And maintenance dose is calculated when we multiply clearance with plasma concentration. So very easy, like loading dose depends upon volume of distribution. Maintenance dose depends upon clearance. Now in drug discovery guys, first of all we do the animal studies. Drug discovery, first of all we do animal studies. After animal studies, we write an application. We call it investigational new drug application. So after doing animal studies, we write one application. We call it investigational new drug application. Now in this application, we will take the permission from the government. We will take the permission to start clinical trial. So this is the application in which we take the permission to start the clinical trial. After that, we do clinical trial phase 1, phase 2 and phase 3. Now in phase 1, we mostly check the medicine safety and medicine toxicity. We mostly check the medicine safety and toxicity in normal human beings. In normal human beings, we check the medicine safety and toxicity. In phase 2 clinical trial, we confirm in phase 2 clinical trial, we confirm the medicine efficacy or medicine efficiency. We confirm the medicine efficacy or medicine clinical role, right? And in phase 3, we do the rechecking. We do the rechecking of the phase 2 finding. We do the rechecking of phase 2 finding in a large population. So whatever we do in phase 2, that is rechecked. That is rechecked in phase 3, but in a big population. Also in phase 3, we can also do the drug comparison studies. So drug comparison studies are also done in phase 3. So drug comparison studies also done in phase 3. So in phase 3, we can do the rechecking of the phase 2 in large population, and drug comparison studies are done in phase 3. And after the success of phase 3, drug will get an approval. Sorry. After the phase 3, the company will write application. We call it new drug application. Now in this new drug application, company will seek a permission to launch the medicine in the market. And when the company will get a permission, a drug is launched in the market. When the drug is launched in the market, its phase 4 clinical trial starts. That is known as post-marketing surveillance. When the post-marketing surveillance, drug-drug interactions can be studied. So drug-drug interactions can be studied in phase 4. Special population like children and pregnant female can be the part of phase 4 trial. Can be the part of phase 4 trial. So this is how a drug is discovered. We have discussed in short. Guys, Indian government has made a drug and cosmetic act for the regularization of the pharmaceutical industry. So according to this drug and cosmetic act, there are some medicines which are schedule H medicines. So these medicines are the one that you will get only on the prescription. So these are the prescription drugs that you will not get without prescription. Now schedule X medicines are those medicines which have abusive capacity. Now guys, schedule C, vaccines and sera. Vaccines and sera which require special storage conditions. So these are the vaccines and sera which require special storage condition. They're classified under Schedule C. Now Schedule P tells you about the medicine expiry date. This will tell you about the medicine expiry date, right? As well as the shelf life. This will tell you about the medicine shelf life or the expiry date. Now Schedule Y will tell you about the rules and regulations of clinical trials. This will tell you about rules and regulation of clinical trials. So in this Drug and Cosmetic Act, there are around 25 schedules. Out of the 25 schedules, we have discussed some important one that can be asked in the exam. So Schedule Y is for rules and regulation. Schedule P is for expiry date. Schedule C is for vaccine and sera. Schedule X is for abusive drugs. Schedule H is for prescription drugs. Right, guys? This is all about general pharma. Now, after general pharma, let's talk about some important topics of endocrine. Then the small topics which are left, I will just share the notes with you directly. So I'll fulfill all the notes of small topics. You can read by yourself, right? So guys, we have anti-diabetic drugs. In endocrine, we have anti-diabetic medicines. So anti-diabetic medicines, we have insulin. Insulin can be of 4 types: rapid acting, short acting, intermediate acting, long acting. Now, rapid acting medicines are glulisine, aspart, and lispro. And these medicines, rapid acting, they can be given by subcutaneous route, can be given by IV route. Now, for IV route, I can use these medicines for diabetic ketoacidosis. If I talk about regular insulin, now regular insulin can also be given by subcutaneous route as well as by IV route. And it's a drug of choice for diabetic ketoacidosis. So it is a drug of choice for diabetic ketoacidosis. That's a regular insulin. Siddharth, we will finish in 10-15 minutes. So there is no point of taking the break right now. Hai na? SAB, it's already 11:40, 11:50. If we take the break, we will cross the day. It will give us a feeling that we started yesterday. So why to have that feeling? Yes, the class will end after endo, and the topics which are left like GAT and autocoids, those are the small topics, autocoids and GAT. So that for that I will share the full notes with you, right? Now the insulin semilente is also known as zinc amorphous insulin. Zinc amorphous insulin. Now we have some intermediate acting insulin like NPH and the lente insulin. Now if we talk about the lente insulin is 30% of semi-lente, 30% of semi-lente and 70% of ultra-lente. 30% semi-lente, 70%. Mama has a feeling that class started yesterday morning. Okay, Mama, no problem. You have the feeling started yesterday, and now you have the feeling it's going to end now. With this feeling, just stay here, stay with us for 10-15 minutes because without you, we cannot continue the class. You are the most important person here for us. Or guys, you want me to share this endocrine notes also? Do you want me to discuss this endocrine with you or shall I share full notes with you? What do you want? Anyone here? Shall I share the notes with you after filling all this PDF? Discuss. Okay, want to discuss. Okay. Okay. So guys, we have some long-acting medicines. Long-acting medicines are ultra-lente. We have the medicines like glargine. Now, glargine is a medicine which is present at acidic pH. And because it is present at acidic pH, it should not be mixed with other insulins. It should not be mixed with other insulin because it is present at acidic pH. Now, insulin detamer is known as 1:4 insulin. It is known as 1:4 insulin. It means 1 unit of insulin contains 4 moles. 1 unit of drug contains 4 moles of drug. Right? So 1 unit of drug contains 4 moles of insulin. We call it 1:4 insulin. Now, insulin deglutide is the longest acting insulin. It is the longest acting insulin, insulin deglutide, and the structure wise, it is most close to natural insulin. Structure wise, it is most close to natural insulin. Longest acting insulin, deglutide, most close to natural insulin, deglutide. Detamer is known as 1:4 insulin. Glargine is acidic pH insulin, and ultralente is the insulin which is also known as zinc crystalline insulin. This is known as zinc crystalline insulin. Right? Yes. Now, guys, most common site of insulin injection, subcutaneous injection, is anterior abdominal wall. So, most common site is anterior abdominal wall, leaving periumbilical area. So, most common site, anterior abdominal wall, leaving periumbilical area. This is the most common site of insulin injections. Now, guys, we have the medicines. The first group of medicine, insulin, we have covered. The second group of medicine that we use for, yes, we know that Mama, you are the very serious student and you are definitely going to clear the exam. So we know that you are listening the lecture. Yes, पेट पर अम्बिलिकस छोड़कर आपको इंजेक्शन देना है, राइट? अम्बिलिकस के पास ना मसल है रेक्टस एब्डोमिनस. So if you give injection around umbilicus, so the dose that you have given for subcutaneous route that will go to muscles that become intramuscular, and once it will become intramuscular, then there's a chances of hypoglycemia. That's why we will leave this area. This area we leave. Rest of the areas are shown in this diagram. Insulin secretococs are the medicines that can result in increased insulin secretion. This can increase the insulin secretion. So, medicines are potassium channel blocker like sulfonylureas and magnetides. Now, these medicines are the old medicines used to cause hypoglycemia. Medicines can cause weight gain and these medicines can increase the risk of coronary artery disease. So there is revolution that has happened in field of diabetes. So we people discovered GLP-1 analogs, we call them glutides, and we have the DPP-4 inhibitors, we call them gliptins. Now these medicines will not cause hypoglycemia. So these medicines will not cause hypoglycemia. These medicines will not cause weight gain, and these medicines can reduce, these medicines will not increase the risk of CAD. Medicines will not increase the risk of CAD. So all three problems of the medicines we have overcome. So three problems were hypoglycemia, weight gain, and coronary artery disease. Now these three problems will not occur with GLP-1 analogs and DPP-4 inhibitors. Now the medicines which are GLP-1 analogs, all these medicines end with the word glutide, and the medicines which are DPP-4 inhibitors, all these medicines end with the word gliptin. Now these medicines are given by subcutaneous route except one drug. There is one drug over here that can be given by oral route, can be given by subcutaneous route. Who will tell me the name of a drug here that can be given by oral route? Now here all medicines are given by oral route. Now if we talk about their mechanism of action, very good. So here the drug is semaglutide. So semaglutide is a drug which can be given by oral route, can be given by subcutaneous route. So guys, if we talk about the fed state, in fed state, this will increase the release of insulin. This will increase insulin and decrease the glucagon. Now same here, they will also increase the insulin and decrease the glucagon. Right? Now in fasting states, they have no effect on insulin. They have no effect on glucagon. But these medicines can increase glucagon. Now they have no effect on the level of GLP-1 and GIP, but these medicines can increase the level of GLP and GIP. They can increase the level of GLP and GIP. Guys, this is one of the prospective MCQ, right? So they can increase the level of glucagon in fasting state because of this GIP. So GIP is the one that is responsible for increasing the glucagon. Now these medicines have got approval for obesity. So they are approved for the treatment of obesity. So we have the medicines like liraglutide and semaglutide. So liraglutide, semaglutide, they are given for obesity. Now these medicines are not approved. These medicines are not approved. Now these medicines can reduce the risk of coronary artery disease, as well as these medicines can reduce the risk of diabetic retinopathy. So they can reduce the risk of coronary artery disease, macroangiopathy, as well as microangiopathy, except a medicine semaglutide. Semaglutide is a drug that can increase the risk of retinopathy. Now, these medicines have no such effect. These medicines have no such effect. Now, these medicines are safe in CKD. All these medicines are safe in CKD. So, all these medicines are safe except a drug, exenatide. So, exenatide is the only medicine which is unsafe. Rest of the medicines are safe. Now, these medicines dose need to be decreased in CKD. These medicines are unsafe in CKD. Their dose need to be decreased in CKD, except linagliptin. So linagliptin is a drug that starts from letter Li. This is exclusively metabolized by liver. This is exclusively metabolized by the liver. So this is metabolized. This is metabolized by liver. So this is the only drug here which is safe to use in CKD. If we talk about their important side effect, now these medicines can reduce the GIT peristalsis. Now because they can reduce the GIT peristalsis, they can cause nausea, vomiting as the most common side effect. They can also cause gastroparesis. They can also cause gastroparesis, nausea, vomiting. They can cause gallstone. These medicines can cause gallstone as a side effect. Now one of the important side effects of these medicine is inflammation. So these medicines can cause inflammation. So the most common side effect is nasopharyngitis. Medicine most common side effect is nasopharyngitis. So medicines can cause nasopharyngitis. These medicines can cause skin ulcers due to inflammation. Medicines can precipitate inflammatory bowel disease. Medicines can also cause myalgia. Medicines can also cause myalgia, arthralgia. Medicines can cause myalgia, arthralgia because of this inflammation, right? Medicines can cause nasopharyngitis, skin ulceration, inflammatory bowel disease, myalgia, arthralgia as a side effect because of inflammation. Dr. Satish Kumar, glucagon, see, you can see here, GLP-1 analogs, they have no effect on GLP-1 and GIP. So GLP-1, GIP remain normal. But when we give DPP-4 inhibitor, their metabolism is inhibited. So GLP-1 and GIP level will increase. And because here the GIP level is increased, this GIP has a tendency to increase glucagon in a fasting state so that the patient will not get the hypoglycemia. So patient will not get the hypoglycemia if you have the glucagon released in the fasting state. So this is due to this property of GIP. But if we talk about GLP-1, they directly act on GLP-1 receptor. GLP-1 analogs, they will directly act on the GLP-1 receptor. They don't have any GIP-like effect. That's why they will not increase glucagon in fasting state. Now guys, there is a new medicine, tirzepatide. Now tirzepatide is a dual GLP-1 and GIP analog. This is a dual GLP-1 and GIP analog, and this medicine also has got approval for obesity. Now guys, there are three medicines which have become the first line drug for obesity. First line medicines for obesity, one is tirzepatide and the other two medicines are these. So liraglutide, semaglutide and tirzepatide. These medicines are the three medicines which have got approval for obesity and they become the first line medicines. Now, after that guys, we have the drugs which can reduce the insulin resistance. Third group of anti-diabetic medicines which can reduce the insulin resistance. Now pioglitazone, this can reduce the resistance by acting on PPAR gamma receptor. This medicine can increase the medicine will act on PPAR gamma receptor. Now this medicine has been outdated because of the bladder cancer as a side effect. So because of the bladder cancer as a side effect, this is outdated medicine. Now metformin is a drug. This is a drug of choice for diabetes mellitus 2. It is a drug of choice for diabetes mellitus 2. This medicine can also cause weight loss and medicine can also reduce the risk of coronary artery disease. So this can cause weight loss, this can cause reduce risk of coronary artery disease and given for diabetes mellitus 2. And if we talk about the important side effect, this medicine can cause nausea as a most common side effect. Will result in nausea, vitamin B12 deficiency and lactic acidosis as a side effect. So lactic acidosis, vitamin B12 deficiency, nausea as a side effect. Now the medicines, yes, it can also be given for PCOD, no doubt about that. Metformin is also given for the treatment of PCOD. Now the medicines which can increase glucose elimination out of the body. So the medicines which can increase glucose elimination. So this topic we have already covered. SGLT2 inhibitors we people have already covered in topic of kidney. Now we have the medicines which are alpha glucosidase inhibitor. These medicines are like acarbose and voglibose. So acarbose and voglibose, these are the drugs which are alpha glucosidase inhibitor. They stop the glucose absorption from small intestine, right? They stop the absorption of glucose from the intestine, right? No, Satish, Dr. Satish, metformin has no anti-cancer property. Metformin has no anti-cancer property. Now the medicines which are given for hyperthyroidism. So medicines which are given for hyperthyroidism, we have the drugs which are hormone synthesis inhibitors. So hormone synthesis inhibitor, they are the thyroid peroxidase enzyme inhibitors. Thyroid peroxidase enzyme inhibitors. We have the drugs like carbimazole and we have a drug propylthiouracil. So medicines which are given for Graves' disease, they are the hormone synthesis inhibitor of thyroid peroxidase enzyme. So by inhibiting thyroid peroxidase enzyme, they can stop the hormone synthesis. Medicines are carbimazole and propylthiouracil. Now carbimazole is a medicine. It's a drug of choice for maintenance treatment of Graves' disease or hyperthyroidism. Now propylthiouracil is a medicine. This is a drug of choice for thyrotoxicosis. Drug of choice for thyrotoxicosis. Now carbimazole is drug of choice for hyperthyroidism in second and third trimester of pregnancy. So in second and third trimester, this is a drug of choice. Now propylthiouracil is drug of choice for hyperthyroidism in first trimester. So in first trimester of pregnancy, this is propylthiouracil is a drug of choice. Now, one of the important side effects of carbimazole is agranulocytosis. One of the important side effect is agranulocytosis, and in pregnant patients, medicine can cause aplasia cutis. So fetus can born with aplasia cutis if given in first trimester. If given in first trimester, fetus can have aplasia cutis. Otherwise, in normal patients, this will cause agranulocytosis. Now, propylthiouracil can cause hepatotoxicity as a side effect. But if the patient is pregnant, this hepatotoxicity become very severe and become fulminant hepatitis, permanent failure of the liver. Fulminant hepatitis can occur in pregnancy, right? Now, the medicines which are hormone release inhibitors, we call them iodides. We call them iodides. So we have the drugs like sodium iodide, potassium iodide. We have the medicine like Lugol's iodine. So Lugol's iodine, sodium iodide, potassium iodide. Now we have the medicines which are peripheral conversion inhibitors. Now peripheral conversion inhibitors, medicines names are propylthiouracil. They inhibit the conversion of T4 to T3. So we have the propylthiouracil. We have the medicine like propranolol. We have the medicine like steroids, prednisolone. So all these three medicines start from alphabet P. They are the peripheral conversion inhibitors. Now guys, whenever the patient will have the thyrotoxicosis, whenever any patient of thyrotoxicosis come to you, how will you treat the patient? So you start propylthiouracil. Propylthiouracil inhibit the synthesis of thyroid hormone. Plus, this will also inhibit the conversion of T4 to T3. So propylthiouracil is considered as overall drug of choice. But along with propylthiouracil, you also start propranolol. So propranolol is a drug that is started to treat the associated symptoms like tachycardia, like the blood pressure, like the arrhythmia. So this medicine has anti-arrhythmic property. This can also stabilize the central nervous system. It has a CNS depressant property. This is given to control tachycardia, high blood pressure, arrhythmia, CNS excitation. All this is controlled by propranolol. But guys, you must be knowing propranolol belongs to class generation 1. So if the patient is a case of bronchial asthma and COPD, we can give the other beta blockers which have the same property like ismolol and metoprolol. So we can give the other beta blockers like ismolol and metoprolol. So guys, please never mention that propranolol is given for this property. Propranolol is not required to be given for inhibition of peripheral conversion. Try to understand. Peripheral conversion is already blocked by propylthiouracil. So here the propranolol has a different purpose. It is not given as an anti-thyroid drug. When this combination is not able to control the disease, we will add the iodides. We will add iodides. Now guys, the problem is all the iodides which were the part of the hyperthyroidism, these medicines have been banned. Because these medicines have been banned in US, in foreign countries. So nowadays we give a radio contrast material. Radio contrast material, we call it sodium iodate. So sodium iodate is a radio contrast material that we use by IV route to inhibit the hormone release. So this is inhibitor of hormone release. Now, even if it is also not able to control, we can give steroids. So third medicine we can give to the patient is steroids. So steroid is a third group of medicine that we can use for thyrotoxicosis. Now apart from that guys, for the treatment of fever, for the treatment of high grade fever in this patient, we will give paracetamol, but other NSAIDs are contraindicated. So other NSAIDs are contraindicated. If patient will have the high grade fever, we will give paracetamol. Other NSAIDs like aspirin is contraindicated. Now apart from that guys, diltiazem. Diltiazem is one more drug that can be given to control arrhythmia. That can be given to control arrhythmia if it is not controlled by beta blockers. If beta blockers are not able to control arrhythmia, then we will give diltiazem. First drug to be given. Actually, Dr. Satish, there is no guidelines which says which is first drug to be given. So if you ask me which is the fastest, which medicine provides fastest symptomatic relief. So the medicine that will provide fastest symptomatic relief is propranolol. So propranolol is a drug that will provide fastest symptomatic relief. But which is given first, there is no such rule because we have to give the medicine back to back. Right? So PTU is a drug of choice. You can give it first. You can give propranolol also first. There is no rule, but fastest is propranolol to control the symptoms and give relief to the patients. Now the medicines which are given for osteoporosis, there are some medicines which are anabolic drugs. They will stimulate the osteoblast and result in bone formation. These medicines are teriparatide, which is a parathyroid hormone analog, and second is romosozumab. Second drug is romosozumab. Now romosozumab is a sclerostin protein inhibitor. It is a sclerostin protein inhibitor. The drug name is romosozumab. So romosozumab, teriparatide are the anabolic drug, and the medicines which are anti-resorptive drug, bisphosphonates. So bisphosphonates are the drug of choice, but we can also use other medicines. We can also use other medicines like raloxifene. So raloxifene can be used, strontium can be there. So we have other medicines like raloxifene, strontium, but all these are not very useful drug. Main drug is bisphosphonates. So bisphosphonates is the main drug that you should remember. Right? So bisphosphonates are drug of choice for osteoporosis. The rest of the details of these medicines you can cover in orthopedics. So in orthopedics, you can cover the rest of the details of these medicines. Right? Guys, these estrogen drugs and all these medicines will be covered in your gynae ops. So gynae ops faculty will teach you all these estrogen containing drugs or progesterone drugs. So after this topic is over. So from my side, the important topics of endocrine I have covered. Diabetes and the thyroid are the two main topics from where you can expect the MCQ. Take care, guys. Thanks for a wonderful audience because you people are sitting there for such a long time. Take care of yourself. All the best. My wishes are with you.
Alright guys, so I hope this one shot program was very useful for you, है ना? So can I say that the entire subject was revised in a very quick amount of time? But as I told you earlier, this is not the end. Now what you have to do is, you have to attempt the test. And how will you attempt the test? You have to download the Egurukal app if you have not done it. And in this Egurukal app, go to the test section. In the test section, go to the QR test, and in this QR test, you will see the test of this subject. Click on that test, gallery or camera. They will ask for a QR code, and here is the QR code. Scan this QR code or download it and put it into your gallery, whichever option that you want, and you are good to go. Please make sure that you are not finishing your day without attempting the test. I wish you all the best for the test as well as happy reading, and I am sure that you will reach to the success in the exam ahead. Take care and God bless you all.